Hello everyone. Very good morning to all of you. Am I clearly visible, audible? Let me confirm. If I'm clearly visible, audible, I will start the class ahead. Okay. Yes, I hope it's working. So, okay, just a second. Am I clearly visible, audible to you guys? You can give me a thumbs up in the chat box if I'm clearly visible, audible to you. Can you see my PDF? Can you see me? Can you hear me? So I welcome you all for today's session. A very good morning to all of you. I am Dr. Priyanka Sachdev here, and today I am here to take a crash course of pharmacology specifically for second prof MBBS students who are going to write their university exam this year. So we have launched this crash course yesterday for pharmacology. Yesterday we have completed complete general pharmacology. We have completed pharmacokinetics. We have completed pharmacodynamics. Those students who have missed the live lectures, they must watch the recordings of pharmacokinetics and dynamics. They are available on YouTube as well as on the app. Now, today I am going to start with systemic pharmacology, right? So I am starting with systemic pharmacology. In systemic pharmacology, today I will teach you two systems, important long questions and short questions, very short questions from two systems, the two very important and difficult systems of entire pharmacology, I guess. So this cardiovascular system, CVS, I will take first, and after that I will start with CNS. Give me a thumbs up. Shall I go ahead with CVS? So I'm starting with CVS now. In cardiovascular system, there are 5 chapters to be covered. So let me start with the first chapter, that is drugs affecting RAS. Drugs affecting renin-angiotensin system. This is the first system I am covering. After that, I will come on heart failure drugs. I will come on antiarrhythmic drugs, anti-angina drugs, or antihypertensive drugs. So I will be discussing the important questions for university exam writing. Shall I start? Okay. So I'm starting with the first chapter, drugs affecting renin-angiotensin system. Before starting, there is a very important announcement for you. Exciting offer is going on Unacademy, that is Unacademy Learning Festival. So in this offer, all the students can avail Unacademy Plus subscription at just rupees 299. So if you pay rupees 299, you will get one complete month plus subscription of Unacademy, right? So you can use that complete subscription for 1 month for live classes, recorded classes for the top educators. There is a question bank containing more than 25,000 questions, practice question. You can give live test, quizzes, all India mock test, grand test, and you can join the batch courses also. So it's very exciting offer. It's a lifetime opportunity. This offer will never come again. So if you want to grab this opportunity, please apply my code before payment. My code is SACHDEV, Sachdev. That is my surname, Dr. Priyanka Sachdev. So Sachdev 10 is the code. So please apply without any space, it's 10. So please apply this code before payment if you want to avail this offer. So thank you very much. So without wasting any time, I'm starting drugs affecting renin-angiotensin system. Drugs affecting RAS. Okay, I will start the drug. I'm having a fixed protocol in which I teach pharmacology to the students. So I teach the classification, then mechanism of action, then uses, then adverse effects, then contraindications, then interactions, and pharmacokinetics. So these are the fixed row of headings under which you should be able to describe all the important drugs, the prototype drugs in entire pharmacology, right? So I will teach you the entire renin angiotensin system inhibiting drugs in a comparative manner under these headings only. But before that, I would like to show you what is renin-angiotensin system. So what is renin-angiotensin system? In renin-angiotensin system, you must understand humans have a pair of kidney. In pair of kidney, we have 1 million nephron. Each kidney have 1 million nephron. Nephron is the structural and functional unit of kidney. We know that. In nephron, we have glomerulus. In the glomerulus, we have a afferent arteriole. It will form a tuft of capillary, and there is a efferent arteriole. On the afferent arteriole, we have a specialized cells. The name of this cells is JJ apparatus, that is juxtaglomerular cells. So inside kidney, so we have kidney, humans have kidney. Inside the kidney we have nephron. Inside the nephron on afferent arteriole, we have a specialized cells that is known as JJ cells. Can you see? These are the JJ cells here. You can see these are on the afferent arteriole. On the afferent arteriole, a specialized group. So what is their function? So normally they are inactive, but whenever humans have decreased BP due to any reason, suppose any of the patient have vomiting, have diarrhea, have fall in BP due to any reason, right? Have accident, have blood loss due to any reason, sudden postural change, sudden fall in BP. At that time, due to the fall in BP, what is happening? All the organs in human body, the blood pressure is less now. So all the organs in human body receive less perfusion because the blood pressure is less. So kidney is most sensitive organ for the pressure. for the blood pressure. So when all the organs in human body from head to toe, they receive less blood perfusion, kidney also receives less blood perfusion. At that time, JJ apparatus inside the nephron of the kidney will become activated, and it secretes the enzyme in the blood. The name of the enzyme is renin. Renin is the enzyme. You got my point? Now see, this is a simplified diagram I have drawn for you people to understand. Now listen, can you see a blood vessel? Osama, Tejaswini, can you see a blood vessel in this diagram? Yes, you all can see a blood vessel in this diagram. Can you see liver? This is liver. Liver form a protein. No, name of this protein is angiotensinogen. It is present in all human blood. It is present in you, me, everyone. We all have angiotensinogen in our blood. We all have angiotensinogen in our blood. Now, whenever fall in BP takes place, due to the fall in BP, due to any reason, at that time, kidney become active. Inside the kidney, the JJ apparatus present in the nephron of the afferent arteriole become active, and it secrete renin in the blood. It secrete renin in the blood. Renin is an enzyme which act on this protein. The protein is formed by the liver, but the enzyme is formed by the kidney. Renin convert angiotensinogen into angiotensin 1. It is another protein. So angiotensinogen get converted to angiotensin 1 by an enzyme. The name of the enzyme is renin, and this enzyme is secreted by kidney. The protein is secreted by liver. You got my point? Now this angiotensin 1 will go to the lung. In the lungs, second enzyme is secreted from the lungs. The name of second enzyme is ACE, that is angiotensin converting enzyme, ACE, because this enzyme convert angiotensin 1 to angiotensin 2. That's why the name given to this enzyme is angiotensin converting enzyme, ACE. You got my point? So in total, there are 3 proteins, 1, 2 and 3, and 2 enzymes, renin and ACE. Renin is secreted by kidney, ACE is secreted by lungs, and we are having 3 proteins. The first protein is angiotensinogen, which is secreted by liver. It convert into angiotensin 1 by renin, and angiotensin 1 get converted into angiotensin 2 by ACE. I don't think any one of you have any problem. So this family is known as RAS family. There are 3 proteins and 2 enzymes. Together, these all together known as RAS. Give me a thumbs up. That is renin angiotensin system. So there is an enzyme renin and angiotensin proteins are there. It is known as RAS system. Give me a thumbs up. Now, after coming in blood, angiotensin 2 will go on 6 organs. I will tell you the name of the 6 organs. It will go on 6 organs in human body. It is having its receptor on 6 organs. On each of that organ, it will cause rise in BP, and ultimately BP is raised, because renin, the main function of coming in blood in renin is fall in BP. Whenever there is fall in BP, at that time renin is coming in role. Otherwise, renin is not coming in role. You got my point? You got my point? Shall I repeat, or is it clear to you? Just a second. Give me a minute. So you see again. So what is the problem? I have told you that humans have a pair of kidney. Inside the kidney, we have nephron. Nephron ke afferent arteriole pe, we are having a specialized group of cell that is known as JJ apparatus. This JJ apparatus usually it is present in all of us, you, me, everyone. I'm telling you normal phenomenon. So there is a backup. There is a family of enzymes and protein given by the God in our blood. So what is this backup? Whenever humans have fallen BP due to any reason, due to blood loss, due to vomiting, due to diarrhea, due to dehydration, due to sudden accident, due to postural change, if we sudden get up from a supine position, if we sudden stand up, so there is fall in BP. So fall in BP due to cardiogenic shock, due to any reason, if fall in BP is there, at that time all the organs in human body receive less perfusion, because the pressure in the blood is less. So from head to toe all organs receive less perfusion, but kidney is most sensitive in them. So kidney also receives less blood pressure, less blood perfusion. At that time kidney become, the JJ apparatus inside the kidney become active, and that JJ apparatus secrete renin in the blood. So see, there is a protein in all of our blood. There is a protein, it is known as angiotensinogen. Currently also this protein present in you, me, everyone. All of us have angiotensinogen, but it is inactive. It is secreted by liver. So liver form a protein known as angiotensinogen. Whenever fall in BP is there, at that time kidney ka JJ apparatus secrete renin in the blood, and this renin converts angiotensinogen into angiotensin 1. Now this is another protein, angiotensin 1. It is also inactive. So this one is inactive. This one is also inactive, right? Now this angiotensin 1 will go to the lungs. Lungs will secrete second enzyme. The name of the enzyme is angiotensin converting enzyme known as ACE. Angiotensin converting enzyme, because it converts angiotensin 1 to angiotensin 2. This angiotensin 2 is active. So we want to convert angiotensinogen into angiotensin 1 and angiotensin 1 to angiotensin 2. So there are 3 proteins. First 2 are inactive. The third one is the active. For this conversion, basically we require two enzymes. The name of the enzymes is renin and ACE. Renin is secreted by kidney, ACE is secreted by lungs. What is the full form of ACE? Angiotensin converting enzyme. Give me a thumbs up. Everyone give me a thumbs up. So the family of the 3 proteins along with 2 enzymes, this family is known as RAS family. That is renin angiotensin system family. So now after coming in the blood, this angiotensin 2, can you see this angiotensin 2? After it is active, it will go on 6 organs from the blood. I will tell you the name of the 6 organs. So the name of the 6 organs, the first organ, it will go on the heart. The second, it will go on the blood vessels coming out of the heart, the arteries of the heart, right, coming out. So aorta and the arteries. So blood vessels, heart. After that, it will go on the brain, in the brain. The nerves coming out of the brain, the sympathetic nerves coming out of the brain. It will go on the kidney, and above the kidney, we have a gland that is adrenal. So it will go on 6 organs, heart and blood vessels, brain and nerves, and kidney, and just above the kidney, adrenal. So learn like 2, 2, 2, total 6 organs. On all these 6 organs, there are receptors for angiotensin 2. What is the name of the receptors? AT1. Angiotensin 1 is the name of the receptor for angiotensin 2. Now don't get confused between 1 and 2. The molecule, the protein is angiotensin 2, but the name of its receptor is AT1. AT1. So all these organs have AT1 receptors on them. So angiotensin 2 will go on each of them and causes rise in BP. So ultimate result is rise in BP. So after rising, BP become normalized because it was initially fault. So the system come in role only when fall in BP. Otherwise, currently in me, in you, this system is inactive. We have angiotensinogen in our blood, but the system will become active when renin come in role. If renin is not coming in the role, system will not become active. This complete system. Everyone give me a thumbs up. Everyone means everyone. So this is the story I taught you. So decrease BP, fall in BP. Because whenever there is fall in BP, angiotensinogen are always present in blood secreted by liver. It is a protein. So at fall in BP, renin will come in role, which comes from the kidney. Renin convert angiotensin 1, angiotensinogen to angiotensin 1. ACE is another enzyme which come in role from the lung, right? Angiotensin 1 convert into angiotensin 2 by ACE. Angiotensin 2 is active. Further, it will convert into 3 and 4 and ultimately get degraded. So I'm not interested in 3, 4. I'm not interested in 1. I'm interested in angiotensin 2, which is the active molecule. So most active among all these is angiotensin 2. Ultimately, it will degrade it into 3 and 4. Everyone give me a thumbs up. Same story here. It is written from the EDT. You can see, yeah. One more thing I would like to tell you. What are the name of the 2 enzymes? There are 3 proteins and 2 enzymes in this family, no? So Wasim, Ashwin, Osama, Tejaswini. You tell me, what are the 2 enzymes here? Can you tell me the 2 enzymes? So yes, the 2 enzymes, the first enzyme is renin, which is secreted by kidney, and the second enzyme is ACE, right, which is secreted by lung. So the renin, what is the function of renin? It converts angiotensinogen to angiotensin 1. Okay. What is the function of ACE? It converts angiotensin 1 to angiotensin 2. There is one more function of ACE. ACE have a double role. ACE have a double role. The first role, it converts angiotensin 1 to angiotensin 2. Name the organ from which ACE is released. Name the organ. It is released from lungs. Can you see it is released from lungs? So these are the lungs, right? In the lung, why it is present? In the lung, in human lung, always there is a substance formation as a byproduct. The name of the substance is bradykinin and substance B. It is formed in all of us. It is constantly formed in our lungs, in our trachea. It is constantly formed, but it causes cough. It causes cough. Bradykinin and substance B, it causes cough. It can cause allergy. It can cause anaphylaxis. All these things can happen. So ACE convert bradykinin and substance P into inactive products. So can you see here also I have written ACE. So ACE have double role. Normally in the lungs, it does this function. In the lung, currently in me, in you, it is constantly performing this function. It converts our bradykinin and substance P into inactive products. If it do not convert, so bradykinin and substance P will cause the cough and edema. So these will be the side effects of bradykinin and substance P. So ACE constantly degrade them and convert them into inactive. But when fallen BP is there, at that time, ACE will convert angiotensin 1 and 2 and angiotensin 2 also. So ACE have a double role. Normally, this is the role. But when fallen BP is there, this is also the role during fallen BP. So this is the double role of ACE. You must understand. Everyone give me a thumbs up. Everyone. So this is the same story written in front of you. So what I have taught you till now, angiotensinogen convert into angiotensin 1 by the enzyme. The name of the enzyme is renin. Then angiotensin 1 convert into angiotensin 2 by another enzyme. The name of the enzyme is ACE. But ACE have a double role. On one side, see, it is converting angiotensin 1 to 2. On other side, it is converting bradykinin to inactive products. Bradykinin and substance P into inactive products. So please appreciate everyone the double role of ACE. This role and this role. Everyone give me a thumbs up. Angiotensin 2 will go to its receptor. So where are the receptors? Angiotensin 2 will go to AT1 receptors. These receptors are present on 6 organs. See further extension of the diagram. Everyone give me a thumbs up. Can you see here? This is angiotensin 2. Now you got how angiotensin 2 is formed in blood. You already got it. Now after forming in the blood, it is going on 6 organs. Can you see the 6 organs? Yes. The first organ is the blood vessel. Can you see? On which can you appreciate the receptors? The name of the receptors is AT1 receptor. The second organ is the heart. This is the heart. Can you appreciate the receptors? Yes, AT1 receptor. The third organ is the kidney. On the kidney also we have AT1 receptors. The fourth organ is a gland above the kidney. That is adrenal gland. It is also having AT1 receptors. The fifth organ is the brain. On the brain also these are the AT1 receptors. And the nerves coming out of the brain, the sympathetic nerves coming out of the brain, it is also having AT1 receptors. So after forming in blood, this angiotensin 2 will go on these 6 organs, combine with its receptor and do one action on each of them. Let me enumerate the actions. These are the 6 organs: heart and blood vessel coming out of it, kidney, and just above the kidney there is a gland, adrenal cortex, brain, and the sympathetic nerves coming out of it. So learn these 6 organs. Now see, everyone see here how angiotensin 2 acts on each of them and causes rise in BP, because it is coming in role because of fall in BP. Whenever fall in BP is there, at that time kidney is causing activation of the system and angiotensin 2 is formed. So at the blood vessel, it causes vasoconstriction. You only tell me vasoconstriction leads to fall in BP or rise in BP. Of course, vasoconstriction leads to rise in BP. So this function will raise BP. Because of vasoconstriction, there is raised BP. Number 1. On the heart, it increases heart rate, it increases force of contractility, and it causes hypertrophy of the heart. It causes the hypertrophy of the muscle. So all these again increases the blood pressure. So on the heart also it is increasing the rate and force of contraction, because of which blood pressure is increased. Give me a thumbs up. That is the second action on heart. On blood vessel, it is causing vasoconstriction, which increases blood pressure. On heart, it is causing increased rate and increased force of contraction, which further increases blood pressure. Third, I am coming on the kidney. In the kidney, it causes sodium water retention. Sodium water retention, more water in the body, more sodium in the body. Again, it increases blood pressure. So number third, it acts on the kidney, causes sodium water retention. It increases blood pressure. Fourth, it acts on the adrenal gland. Adrenal gland secrete aldosterone, because when angiotensin 2 acts on the adrenal gland will secrete aldosterone. Aldosterone also causes sodium water retention. Aldosterone also causes sodium water retention. You got my point? Which again increase BP. In the brain, it increases the secretion of ADH in the blood. You know what is ADH? ADH stimulates thirst. So patient will feel more and more thirsty. So patient will drink more and more liquid, more and more fluids, more and more water. So again, it increases the blood pressure, right? And last, it acts on the sympathetic nerves, not parasympathetic. There are 2 types of nerves. So it acts on sympathetic nerves, which again causes rise in BP. So by acting on the 6 organs, ultimately the fall in BP become normalized. Everyone give me a thumbs up. Why I taught you this story? So what we have learned, the summary of the story. Whenever we have fall in BP, due to any reason, humans have fall in BP. At that time, the RAS system comes in the role. In the RAS system, we have 3 proteins and we have 2 enzymes. The complete system will come in role, and by angiotensin 2 is the main molecule there, which is active. This will act on 6 organs, the 6 different organs, and ultimately it will rise in BP acting on each organ. So the fall in BP will become normalized. Now here rise in BP, but initially there was fall. So ultimately BP will become normal. Ultimately the person will have normal BP. Everyone give me a thumbs up. Now you tell me, what is hypertension? What is hypertension? Hypertension is rise in BP. It is a disease in which the blood pressure is raised. It is more than 120/80. We know the gradings in the hypertension, right? So pre-hypertension, stage 1, stage 2, we know that. It is hypertension. What is the reason of hypertension? Can you tell me? What is the reason of hypertension? Why hypertension occurs? The primary hypertension. In old age, after 50-60 years, most of the persons are hypertensive. At your home, at my home, our parents, our grandparents, our neighbors, So in the community, we have seen many hypertensive persons. After 50-60 years, most of the persons become hypertensive. What is the reason? What's the reason? Does anyone know the reason of that? Why most of the persons become hypertensive after 50-60 years of age? What happens in their body? In their body, their RAS become overactive. Their RAS become overactive. What do you mean by RAS become overactive? So normally, whenever there is fall in BP, at that time RAS come in role. RAS should active, and because the RAS become active, it should rise the BP. It should rise the BP, and since BP was initially fall and now it is rise, so it become normal. It become normal. But in old age, what happens? In old age, at normal BP also, when BP is not fall, it is normal. Normal BP also, RAS become active. That is overactivity of the RAS, because RAS is overactive in them. So even at normal BP, it come in role. So angiotensin 2 will be formed and it will act on the 6 organs, and acting on each organ, it will cause rise in BP. So here it is rise in BP. So BP will be raised and that will lead to a disease, that is hypertension. So hypertension is basically overactivation of RAS in old age. So in old age, RAS become overactivated. So even at normal blood pressure, it become activated and it causes rise in BP. You got my point? So the point is that whenever BP is fall, RAS is coming in role, so it raises the BP and BP become normal. But initially, if the BP is normal and RAS is coming in the role, so BP will high. And this disease is known as hypertension. Give me a thumbs up. Give me a thumbs up. I want to treat hypertension. In old age, I want to treat hypertension. What should I do? So hypertension is overactivity of the RAS. Overactivity. So I should inhibit RAS. So inhibition of the RAS. Here I am starting my chapter. That was an overview till now. So till now, I have given you an overview that how hypertension occurs and what is the reason we are inhibiting RAS. You tell me at what point I can inhibit the RAS. Tell me the 5 different segments where this system can be inhibited. I want to treat hypertension. I want to treat hypertension. So tell me where I can inhibit the system. Number 1, I can inhibit the release of the renin. So on the kidney, the JJ cells are inhibited. So JJ cells don't secrete renin. If renin aega hi nahi, so the complete system will not come in role. Number 1, renin release can be inhibited by beta blockers. Beta blockers are the drug which act on JJ apparatus of the kidney and they inhibit renin release in the blood. Number 1. So if you are not inhibiting this step, Osam, I'm coming on renin inhibitor. These are renin release inhibitor. I'm telling you, renin ka release ko inhibit karo. If you are not inhibiting the release of the renin, renin will come in the blood. After coming in the blood, you give something which inhibit renin enzyme. So renin inhibitors. So renin release inhibitors, renin inhibitors. I will teach you renin inhibitors. Renin release inhibitors are beta blockers. Right. After that, renin inhibitors, I will teach you the enzyme which inhibits the renin. If you are not inhibiting renin also, so angiotensinogen will convert into angiotensin 1. Now, you do not want to convert angiotensin 1 to 2, so inhibit race. So the third point where we can inhibit is the ACE inhibitors. So we can give renin release inhibitor, we can give renin inhibitor, we can give ACE inhibitor. If I'm not giving any one of them, so ultimately you say, ma'am, angiotensin 2 will form. If you are neither giving renin release inhibitor, not giving renin inhibitor, not giving ACE inhibitor, so what will happen? Ultimately, angiotensin 2 will form. Yes, this angiotensin 2, where it will go? It will go on its receptor. So what is the name of the receptors? What are the name of the receptors? Here we are having 81 receptors. So block the 81 receptors. So angiotensin receptor blocker. So blood mein banne do. In the blood, you let form angiotensin 2. But if it is forming, the receptors are already blocked, so it cannot act on the 6th organ. Now, it will remain in blood only. It cannot go on the 6th organ and act on the 6th organ because the receptors on all those 6 organs are already blocked by a drug. So it is known as renin and receptor blockers, ARB, angiotensin receptor blockers. 81 receptors ko block karenge. So that is the 4th level. Give me a thumbs up. The 5th level, if you are not inhibiting anything. So lastly, from the 6th organ, सबसे main organ है adrenal gland. From the adrenal gland, aldosterone is coming out. This aldosterone causes sodium water retention and causes rise in BP. So you give aldosterone inhibitor. So at least at 5 organs it will acting, but the 6th, that is aldosterone, will be blocked. So there are 5 levels we can block. So what are the 5 levels? Inhibition of RAS. The same is shown to you. You can inhibit RAS at 5 levels. The 5 levels are in front of you. Renin release inhibitor, renin inhibitor, ACE inhibitor, angiotensin receptor blocker, 81 blocker, and aldosterone antagonist. Everyone give me a thumbs up. The 5 levels are in front of you. You have to write like this in your exam. Renin release inhibitor is done by beta blocker. Renin inhibitor is renin inhibitor. ACE inhibitor is ACE inhibitor. Angiotensin receptor blockers are ARBs. And aldosterone antagonist is spironolactone. Everyone give me a thumbs up. Jitne audience hai utne thumbs up do. Have you got it? So these are the 5 levels where we can inhibit the RAS. Out of the 5, I will teach you 3 in this lecture which are most important for your syllabus. I will start with ACE inhibitors, then I will come on renin inhibitors, and then I will come on ARBs. So these are the 3 chapters I am going to teach you. ACE inhibitors, ARBs, renin inhibitors. Right. So this is how I am going to take my chapter. Let me start with ACE inhibitors. So that was an overview. Everyone give me a thumbs up. Kuldeep, Ashwin, Tejaswini, Osama, Have you got it? Shall I start? Oh, I shall start. So the first chapter, so I'm going to teach you 3 chapters now. I will be super fast. These 3 chapters I will teach you in the next 15 minutes. We will complete it. Let me start. The biggest is the ACE inhibitor, and most important for your university exams is the ACE inhibitor. Let me start ACE inhibitors. ACE inhibitors. Every chapter you have to tell me in these headings. First, tell me the classification of ACE inhibitors, how many drugs you know in ACE inhibitors. Then tell me the mechanism of action, tell me the pharmacokinetics, tell me the interactions. For users, I always prefer to give mnemonics. I will give you mnemonics for the users also, adverse effects also, contraindication also. So you will retain it better in your exam. So I will give you mnemonics for all these, for all drugs, not only for this. For maximum drugs, I will give you mnemonics here. But mechanism of action, I will teach you in the form of the diagram and flowchart. So only thing you have to learn is the classification. Mechanism of action you have to understand in the diagram, in the flowchart. You don't have to mug up. And users adverse effect contraindication, I will give you mnemonics. Everyone give me a thumbs up. This is how we will complete it. Okay. Before starting, I would like to tell you one thing here. All ACE inhibitors have a suffix pril. Captopril, enalapril, lisinopril, perindopril, ramipril, fosinopril, quinapril, and pterandopril. Don't add a pril after your name. So learn the prefix also. Right? In your exam, you have to write the exact drug. So pril किसी के भी आगे जोड़ के नहीं कुछ भी नाम बना देना कि pril suffix should be pril and prefix can be anything. No, it cannot be anything. It have to be capto, inala, lisino, parendo, rami, fosino, quina, and pterando. So that is the pril. Give me a thumbs up. All prils are there. All ARBs, angiotensin receptor blockers, 81 blockers. The name of the receptor is 81 on the 6 organs. So 81 blockers are sartans. These all are sartan, losartan, candesartan, valsartan, telmisartan, irbesartan, olmesartan. So you have to learn the prefix as well as suffix. These all are sartans. And rannin inhibitors, the first enzyme rannin coming from JJ apparatus. Rannin direct inhibitors. These are not rannin release inhibitor. Rannin release inhibitor are beta blocker that I am not teaching you. Rannin inhibitor are known as kiran. The suffix is kiran. Here only one kiran is written, but many kirans are there. So Alice kiran is the first kiran, but many kirans are there. So we have prils, we have sartans, we have kirans. We have 3 type of drugs. Prils, sartans, and kirans. Everyone give me a thumbs up. Everyone. So shall I start with ACE inhibitors? Shall I start with ACE inhibitors? I must start. So this is the headings under which I am going to describe ACE inhibitors. ACE inhibitors, the drugs are pril. As I have told you, the suffix is pril. Learn the suffix pril, pril, pril. Captopril, enalapril, lisinopril, perindopril, ramipril, fosinopril, quinopril, trandlopril. So please learn all prils. That is the classification. We are done with classification. You write all the drugs with suffix pril, but you have to learn prefix also. Right? Prefix. Students usually don't learn prefix. They add pril after any prefix. They choose prefix of their choice and add pril in that. So you will not get marks if you do that. That's smartness. So don't show this smartness in your university exam. Learn prefix as well as suffix. Right? Coming on mechanism of action. You yourself tell how mechanism of action it will act. It will be useful in hypertension. How it causes fall in BP in hypertensive patient. If I'm giving ACE inhibitor, how it is causing fall in BP? Can you tell me the mechanism of action? Yes. So ACE, whenever you are giving ACE inhibitor, it is inhibiting the enzyme ACE. The rest of the levels are not inhibited. Only ACE is inhibited. So what will happen? If ACE is inhibited, angiotensin 1 cannot be converted to angiotensin 2. Angiotensin 1 will remain as angiotensin 1 only. And angiotensin 2 is not formed. If angiotensin 2 is not formed, it will not go on blood vessel, AT1 receptor of the blood vessel, and vasoconstriction will not happen. So hypertension will not happen. So fall in BP will happen. You got my point? Osama, Ashwin, you got my point? Tejaswini? So ACE inhibitor normally converts angiotensin 1 to angiotensin 2. We know that. So ACE enzyme converts angiotensin 1 to 2. ACE inhibitors inhibits the ACE enzyme. So angiotensin 1 cannot be converted to angiotensin 2. So angiotensin 2 is not formed. If it is not formed, it will not go on blood vessel AT1 receptor. If it will not go to the blood vessel, it will not cause vasoconstriction. No vasoconstriction means no rise in BP. So both systolic and diastolic BP will fall. Everyone give me a thumbs up. Yes. So that is the thing. That is the thing. So this is the mechanism of action, right? But there is a side effect also. As I have told you, ACE is a double role. It is a double role. On one hand, it converts angiotensin 1 to angiotensin 2. On other hand, in the lung, ACE convert bradykinin and substance P to inactive products, right? Now you are giving ACE inhibitor, so both the ACE will be inhibited. The ACE present in the blood will also be inhibited and the ACE present in the lung will also be inhibited. So You want this to happen in the blood. You want this to happen. You do not want to convert angiotensin 1 to 2. That's why inhibiting ACE here is useful. But in the lung, ACE is inhibited, so bradykinin and substance P will not be converted into inactive products. It will remain as bradykinin and substance P only, and they cause cough. So it is a side effect of ACE inhibitor. ACE inhibitor causes cough, angioedema because of this. So it is a side effect. If you want to inhibit ACE, ACE everywhere in the body will be inhibited. It is not the thing ACE will be inhibited in the blood but not in lung. If you are giving any of the prill, so all prills, ACE inhibitor inhibit the ACE everywhere in the body. In the blood also, in the lung also. In the blood, we want this to happen. We want ACE to be inhibited. It is useful for us for treating hypertension. But in the lung, we do not want it, because in the lung also, if ACE is inhibited, bradykinin and substance P will not convert into inactive products, and it will cause cough. So cough is dry cough is a side effect of ACE inhibitor. This is the reason. This is how you have to write in your exam. ACE enzyme converts bradykinin to inactive products. But whenever we are giving ACE inhibitors, it inhibits ACE enzyme in the lung also. So bradykinin now is not converted to inactive products. So bradykinin and substance P concentration is increased in the lung, and that will lead to cough and angioedema. Everyone give me a thumbs up, and pruritus also, itching also. So this is the side effects. Give me a thumbs up. Give me a thumbs up. You can see ACE. ACE. You are inhibiting ACE here also, here also. This type, you want this inhibition to happen. It is useful to treat BP, to treat hypertension, but this inhibition is not useful because it will lead to cough. So this is how you have to remember. Everyone give me a thumbs up. I am done with classification. In classification, write down all pills. Write down the 7 type of pills you know. In mechanism of action, draw the flow chart, draw the diagram, and in the diagram, explain how ACE inhibition leads to normalizing BP in a hypertensive patient, number 1. And write down the side effect also, one of the side effect, that is cough and angioedema. Coming on pharmacokinetics. Learn the pharmacokinetics only of prototype drug, not all drugs. So here prototype drug is captopril. So learn the pharmacokinetics only one drug. I cannot teach you pharmacokinetics of all 7 pills. I can teach you of only one. So learn the first prototype drug, that is captopril ka pharmacokinetics. It is given orally, bioavailability is 75%, food interferes with absorption, T half is 2 hours, duration of action is 12 hours. So learn that. It is rectification, but you have to learn it, right? Coming on interaction. The next heading is interaction. You learn interaction also by yourself. I will teach you interaction later on. Listen, coming on uses, adverse effect and contraindication. I will give you 3 mnemonics here. See the uses ka mnemonic. First, I am giving you the mnemonic for uses. Mnemonic for uses is home, care, makes, patient, definitely strong. This is my mnemonic. Home, care, makes, patient, definitely strong. What is the full form, by the way? This is the full form. See here, everyone see. Home, H stands for hypertension. Of course, it is the drug of choice for hypertension. Any hypertensive patient coming to your clinic, you start with ACE inhibitor unless until contraindicated. That is the first choice drug in hypertension. Why? We know the reason. Care ka C stands for congestive heart failure. So in congestive heart failure, it reduces BP, it reduces preload also, it reduces afterload also. Basically, ACE inhibitors causes vasodilatation. You got my point? Angiotensin 2 was causing vasoconstriction in the blood vessel, and ACE inhibitor inhibit the formation of angiotensin 2. So ACE inhibitor causes vasodilatation. So vasodilatation of the artery reduces afterload, and vasodilatation of the vein reduces preload. So reduction of preload and afterload is useful for congestive heart failure. Makes ka M is MI. In MI patient also it is useful. It is useful not only in the treatment of MI. For the treatment of MI, you should use ACE inhibitor. For the prophylaxis of MI in high risk patient, imagine a patient is obese, patient is diabetic, patient is having sedentary lifestyle, no exercise. Such patient is at high risk of having MI in future, right? So for prophylaxis also, P for prophylaxis, you can give this. So give it for MI and give it for prophylaxis of MI, right? It can be given. Definitely the D is diabetic nephropathy. You know, in diabetes, 3 organs are damaged: kidney, retina, and nerves. So diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy are the 3 complications of diabetes. So in a diabetic patient, you give ACE inhibitor before nephropathy develops. Or if nephropathy develops, you give at starting. So it delays the progression of the nephropathy. That is in diabetic nephropathy. And strong ka S is scleroderma. In scleroderma, there is high blood pressure. So blood pressure will become normal in scleroderma patient. Everyone give me a thumbs up. So these are the 6 uses. Write few lines on each of them. The most important use is hypertension. In hypertension, as I have told you, it is a drug of choice. It is a drug of choice. It is the drug of choice. Advantages you learn. It do not cause postural hypertension. It do not cause fatigue like beta blockers. It do not cause hypercalcemia like diuretics. It do not cause rebound hypertension like alpha blockers. It is safe in asthmatics and diabetes. In contradict as compared to beta blockers. Beta blockers are not safe in asthmatics. They are not given in diabetics, but ACE inhibitors can be given. So these are the advantages over other antihypertensive drugs. Congestive heart failure, it reduces preload, it reduces afterload. That's why it is useful here. In MI, it is given in the treatment, right? And in prophylaxis of MI also it is given. In diabetic nephropathy, it delays the end-stage renal failure in diabetic patient. And in scleroderma pruritus, the marked rise in BP can be normalized after giving ACE inhibitor. So write one line, two lines for each of them in your exam. Learn the list. What is the list? Home care makes patient definitely strong. Home care makes patient definitely strong. Say the full form. Hypertension, CHF, MI, prophylaxis of MI, diabetic nephropathy, scleroderma. Everyone give me a thumbs up. Jitne audience utni thumbs up. So these are the uses and describe them. Just learn the list. If you are a university exam going to appear in your university exam, just learn the list, enumerate them, and after that describe them in your own language. So how ACE inhibitor is useful in each of them. I guess you got it. Coming on the adverse effects. So uses we are done. Home care makes patient definitely strong. Coming on adverse effects now. Adverse effects. What is the mnemonic for adverse effect? The mnemonic of adverse effect is captopril itself. Captopril. So what is the full form of captopril? Captopril. Captopril. This is the mnemonic for adverse effect. So let me say the full form. C for cough. You know the reason for cough. So because ACE inhibitor causes increased concentration or accumulation of bradykinin and substance P in the lung, that causes cough. The most common side effect is angioedema. It is also because of bradykinin accumulation. And I is itch. Itching is also due to bradykinin. So three side effects are due to bradykinin accumulation, bradykinin and substance P. So C, A and I to ho gaya. Give me a thumbs up. Everyone give me a thumbs up. P for potassium. It causes potassium rise in the blood. It causes potassium rise in the blood. Yes, right. T, okay, I will show you here only. This is captopril. C for cough, we have seen. A for angioneuritic edema, angioedema, and I for itch. These three side effects are due to bradykinin. I have already taught you. P, there are two P. So one P is proteinuria and one P is potassium increase, hyperkalemia. Potassium increase means it causes hyperkalemia. I will tell you the reason for hyperkalemia. Wait a minute. T for there are two T. It causes taste disturbances and it is teratogenic. Don't give ACE inhibitor to any pregnant lady. Right? Low L means low BP. Low BP means you will say, ma'am, we are giving it in hypertension. We want to decrease BP, but by decreasing, we want to normalize it. We don't want a hypertensive patient to become hypotensive after giving ACE inhibitor. We want a hypertensive to become normotensive. But sometimes it overact. Sometimes it exaggerate. Usually first dose के बाद patient को normal की जगह fall in BP हो जाएगा. So don't start with full dose. Start with half dose and gradually increase the dose. This is a rule, right? So patient is having high BP. Right, patient's BP is 160 by 100 right now. You are starting on ACE inhibitor. You want on starting ACE inhibitor, the BP should normalize and it should be 120 by 80. But ACE inhibitors are overacting, and instead of causing 120 by 80, it is causing 100 by 60, 100 by 70. So patient, instead of normotensive, it is becoming hypotensive. You do not want that. That will be a side effect. So overaction is a side effect that can be done, and this is the first dose. Everyone give me a thumbs up. You understand the meaning of all? Now let me teach you the reason for potassium increase. You want me to teach you the reason for the potassium increase? Why potassium is increased? You want me? Okay, give me a minute. I will explain you. This is my diagram. No, I will show you the same diagram. See this diagram. Okay, not this one. This one. In this diagram, you tell me the 6 organs on which it is acting. What are the 6 organs on which angiotensin 2 is acting? How angiotensin 2 is formed? You know how it is acting on the 6th organ. One of the organ is adrenal gland. One of the organ is adrenal gland. Adrenal gland secrete aldosterone. Yes or no? Adrenal gland secrete aldosterone. Yes or no? What does aldosterone do? Aldosterone do sodium and water retention and potassium excretion. This is normal function of aldosterone. You must be knowing. राइट एल्डोस्टेरोन क्या करता है बॉडी में? एल्डोस्टेरोन सोडियम वाटर को रिटेन करता है और पोटेशियम को एक्सक्रीट करता है. यू मे बी नोइंग दैट. नाउ यू आर गिविंग एस इनहिबिटर. अप्लाई नाउ. You are giving ACE inhibitor. If you are giving ACE inhibitor, angiotensin 2 is not formed. If angiotensin 2 is not formed, aldosterone is not formed. So reverse will happen. Aldosterone causes sodium water retention and potassium excretion. No, reverse will happen. Sodium water will be excreted and potassium will be retained. Retention of potassium causes hyperkalemia. Give me a thumbs up. This is how you have to understand the reason for hyperkalemia. Everyone give me a thumbs up. Everyone, jitne audience hai, thumbs up. So you got my point. So this is the master diagram from which you can understand all the uses, all the adverse effect of ACE inhibitors. Everyone give me a thumbs up. So potassium, yes, Kuldeep. So normally aldosterone causes two things. Aldosterone from the adrenal gland, it causes two things. It causes sodium and water ka retention in the blood and potassium ka excretion out of the blood into the urine. But whenever you are giving ACE inhibitors, what ACE inhibitors are doing? ACE inhibitors are inhibiting aldosterone. So there is no aldosterone in the blood. They decrease the formation of aldosterone and secretion of aldosterone. So if there is no aldosterone, so reverse will happen. So initially sodium water retention was happening. Now sodium and water will excrete. Sodium and water will excrete. Okay. So patient will have more urine and potassium will be retained. Retention of potassium will lead to hyperkalemia. That is a side effect. It can lead to arrhythmias. Hyperkalemia can lead to arrhythmias. Give me a thumbs up if you got it. So this is the reason for hyperkalemia. We are done with uses also. We are done with the list of adverse effects also. Give me a thumbs up, everyone. So what are the adverse effects? Who will tell me? Who will tell me? So what are the uses? What are the adverse effects? I told you adverse effect ka mnemonic is captopril. So captopril mein one is the most common adverse effect is first dose hypotension. That is low BP. Cough, you know the reason for cough, right? That is bradykinin accumulation. Angioedema, the same reason, bradykinin. So bradykinin is the reason for cough. Bradykinin is the reason for angioedema. So angioedema is there on the face. Hyperkalemia, I already taught you because of decreased aldosterone. Reverse will happen. You know the reason. You know the reason. Give me a thumbs up. Never give any ACE inhibitor with other drugs which causes hyperkalemia. Because ACE inhibitors also causes hyperkalemia. Patient will have severe hyperkalemia and patient can go in arrhythmia. So never, never, never give ACE inhibitor with any other drug which causes hyperkalemia. What other drugs causes hyperkalemia apart from ACE inhibitors are the interactions. You know, these are the contraindications. These never given with ACE inhibitor. Never give potassium sparing diuretic, potassium supplement, beta blocker, NSAID, succinylcholine in adrenal failure. In these conditions, never give ACE inhibitor because they also cause hyperkalemia. And ACE inhibitor also causes hyperkalemia. You got my point? It is teratogenic. Never give it in pregnant lady. It causes itching. It causes taste disturbance. It causes proteinuria. I am done. So this is captopril, the adverse effect. Coming on contraindication. There are 4 contraindications for ACE inhibitor. The mnemonic is PARK, P-A-R-K. You can understand all 4. P for pregnancy. Never give ACE inhibitor in pregnancy. A for allergy. If the patient is having allergy or hypersensitivity for ACE inhibitor, never give it. K for potassium, hyperkalemia. Never give ACE inhibitor to a patient who is already having hyperkalemia. Before starting ACE inhibitor, check potassium level. If potassium level are normal, then only start ACE inhibitor, otherwise don't start. And R is renal artery stenosis. If the patient is having renal artery stenosis, ACE inhibitors are contraindicated. Everyone give me a thumbs up. Can you tell me uses, adverse effects and contraindication? Can you tell me? Who will tell me? Okay, starting se we will revise. I'm done with the chapter. So the chapter was ACE inhibitor. The summary is in front of you. The chapter was ACE inhibitor. The summary is in front of you. Who will tell me the summary? Classification, it have pril in the suffix. You know the 7 prils. Mechanism of action, as the name indicates, it inhibits the enzyme ACE. So angiotensin 2 is not formed. 1 is not converted to 2. If 2 is not formed, it will not go to the 6th organ. It will not cause rise in BP, so there is fall in BP. This is mechanism of action. Pharmacokinetics, you learn by yourself of the prototype drug, that is captopril. Interactions, I taught you, never give ACE inhibitor with any other drug which causes hyperkalemia. So these all are interactions, the drugs which causes hyperkalemia. Now tell me the uses, mnemonic. Home care makes patient definitely strong. Tell me the adverse effect mnemonic. So captopril, C-A-P-T-O-P-R-I-L, right? And tell me the contraindications mnemonic. The mnemonic is PARK. If you know these 3 mnemonics and the full form, you will get full marks in your exam. It is a 5-mark question. So in 5 marks, you have to write everything and describe them. Now I have written on 1 page. Maybe if you write the complete description, you will write the same answer in 8 to 10 pages. Can you? Yes, you can. So on 1 page, write classification. On 1 page, draw the flowchart with the diagram of mechanism of action. It will take 2 pages. Pharmacokinetics, interaction, uses, describe each of them. So it is hypertension, it is CHF, congestive heart failure, MI, prophylaxis of MI. diabetic nephropathy, and scleroderma. That is the full form. What's the full form of captopril? It is cough. Angioedema, it is hyperpotassium, P for potassium hyperkalemia. Teratogenic, others हैं, these are others. 1P is proteinuria, R is renal artery stenosis, I is itch, and L is low BP. The first dose hypertension. PARK, P-A-R-K. So it is pregnancy, it is renal artery stenosis, it is allergy and hyperkalemia. Everyone give me a thumbs up. So if you know this, I am done with the first chapter, ACE inhibitors. A 5-mark question we have done. So if coming for 5 mark, you have to write everything. If coming for 2 or 3 mark, whatever asked, you have to write that only. If pharmacokinetics is asked, write that only. Mechanism of action is asked, write that only. Classification, so whatever asked, write that portion only, right? If 2 or 3 mark. But if it is a 5 mark, write everything. Everyone give me a thumbs up. Let's start the next chapter. I'm starting the next chapter as ARB. ARB, angiotensin receptor blocker. You tell me, where are angiotensin receptor blocker? Angiotensin receptor blockers are here. They act on the AT1 receptor of all 6 organs. They just block the AT1 receptors of all 6 organs. So angiotensin 2, which is formed in the blood, cannot combine with the 6th organ, cannot act on the 6th organ. So they are blocking. These are the blockers. You got my point? Suppose this is the organ, any of the 6 organ. I taught you in the beginning what are the 6 organ. This is the AT1 receptor on the organ, any of the 6 organ. So these drugs are blocking. These are ARBs, angiotensin receptor blocker. They block the receptor, so that in the blood, when angiotensin 2 is formed, angiotensin 2 try to come here. This is angiotensin 2. It is trying to come here and binding, but the receptor is already blocked, so it cannot bind with the receptor and it will remain in the blood only. So it cannot show its action. So it will not cause rise in BP, it will cause fall in BP. Give me a thumbs up. This is the mechanism of action. You tell me the same headings. Tell me the classification. Classification, all sartans are there. How many sartans? How many sartans? It is losartan, candesartan, valsartan, telmisartan, irbesartan, olmesartan. So these are sartans. Give me a thumbs up. These all are sartans. Mechanism of action, I already taught you. Angiotensin receptor blocker bind with AT1 receptor on the 6 organs. You know the name of the 6 organs, and block the receptor, so that the angiotensin 2, which is present in blood, cannot bind with these receptors, and angiotensin 2 showing no action. So it is not causing hypertension. It will lead to hypotension. Give me a thumbs up. Write this flowchart, draw this flowchart, draw this diagram. Right. Now, how it is different from ACE inhibitor? Can you tell me the differences from ACE inhibitor? So here, you are blocking the receptors. Right? You are blocking the receptors. You are not inhibiting ACE. So there is no cough. There is no cough. Ultimate results are same. ACE inhibitor, by blocking ACE, it was treating hypertension. ARBs, by blocking the AT1 receptors, it is used in the treatment of hypertension. But ACE inhibitors were causing cough, because here bradykinin synthesis was bradykinin was accumulating in the blood. But if you are blocking the AT1 receptors, you are not blocking ACE. So ACE is functional. ACE is functional, right? So ACE will convert bradykinin to inactive products, and there is no cough. The biggest difference is the cough. So bradykinin and substance P will not accumulate here, in contrast to ACE inhibitor. So cough, edema, rashes, itching, these are not side effect of ARBs as compared to ACE inhibitors. You tell me which are better. Which are better for the patient? The patient, ACE inhibitors are better or ARBs are better? So we prefer ARBs for the patient, because the effect is same, but ARBs do not cause these side effects, and ACE inhibitor causes these side effects. So that's why this is the reason why ARB are superior as compared to ACE inhibitor. It is a 2-mark question in university exam. Give me a thumbs up. You have to describe like that. Give me a thumbs up. Uses are same. Exactly same. Home care makes patient definitely strong. So same uses of ARBs, and rather in all these diseases, it is better to give ARB as compared to ACE inhibitor. Adverse effect में से captopril ही है, लेकिन वो तीनों हटा दो. Captopril. Remove the those one which are caused by bradykinin. What are caused by bradykinin? There is no cough here, there is no angioedema, and there is no itch. Remaining adverse effects are common for ACE inhibitors as well as ARB. I cannot super simplify than this. Remaining one are common. So first dose hypertension will happen here also. Give me a thumbs up. Hyperkalemia, potassium increase occur here also. But cough, angioedema, these will not happen. So that is the teratogenic. This is also teratogenic. Give me a thumbs up. We are done with ACE inhibitors. We are done with angiotensin receptor blockers. You got my point? You got my point? Now coming, yes, CAI, you have to remove Sakshi. Very good. Coming on the last, direct renin inhibitors. Direct renin inhibitors. Tell me the drugs. Direct renin inhibitors inhibit the renin. ना बजेगा बांस ना होगी बांसुरी. You got my point. So renin ही नहीं होगा. There is, you just inhibit renin. If renin you are inhibiting, so angiotensinogen will not convert into angiotensin 1. If 1 is not there, 2 will not there. If 2 will not there, it will not go to the 6th organ and not show the action. So you are basically inhibiting renin. So here many drugs are there. Most important is kiran, Alice kiran. Here suffix is kiran, right? Kiran, right? So what is the mechanism of action? It binds with the renin, the catalytic site of renin, and competitively block it. So angiotensinogen cannot convert into angiotensin 1, and angiotensin 1 is not produced. So the chain is interrupted. We are interrupting the chain here. Ultimately, this complete chain has to be interrupted. Give me a thumbs up. So we are interrupting here. Users, it is not very good drug. It is a newer drug, but not very good because it causes fall in BP only by 5 or 10 mm of Hg. So it is not very strong antihypertensive drug, right? So it is never used alone, right? So hypertension, it is used for hypertension, but not alone. It is used in combination. It is used in combination because its efficacy is not very good. It can be used in congestive heart failure, again in combination. It can be used in diabetic nephropathy, but not very good. The uses are same, but we don't prefer it. We use as an alternative antihypertensive drug if the patient is not responding to the first line. It is a second line. These are not first line, and it is used in combination with others. That's it. Adverse effect is dyspepsia. Patient have acidity. Because of the acidity, patient have abdominal pain. Patient have loose motion, headache, dizziness. So non-specific adverse effects are there. I am done with the 3 chapters. Everyone give me a thumbs up. These 3 chapters. The first chapter of CVS is over. The drugs inhibiting RAS. The RAS is the family in which we are having 2 enzymes and 3 proteins. The family of 5 members is known as RAS. We have to interrupt the chain. So interrupt chain at what level? This is the RAS inhibitors. Everyone give me a thumbs up. Jitne audience utni thumbs up. In each of them, you should be able. So there are 3 chapters I taught you. I taught you the first chapter, ACE inhibitors. The second chapter I taught you ARBs. The third chapter I taught you renin inhibitors, direct renin inhibitors. So this is how the second prof students should prepare for their exams. They should be able to tell me the name of the drugs here in each category. They should be able to tell me the mechanism of action, draw the flowchart as well as diagram in each of them, right? You should be able to tell me the pharmacokinetics for the prototype drug of each of them that you have to learn by yourself. You have to tell me the uses, adverse effect, contraindication, and interactions if possible. Everyone give me a thumbs up. Everyone. So here all the drugs are Pril. Here all the drugs are Sartan. Here all the drugs are Kiran. Mechanism of action, draw the same flowchart. In that flowchart, make a cross at different level. You know where you have to make a cross. In ACE inhibitor, make a cross over ACE. So angiotensin 1 cannot be converted to 2, right? In ARP, make a cross over the receptors, 81 receptors. So angiotensin 2 is formed, but it cannot go to its receptor. And then renin inhibitors make a cross over renin. So angiotensinogen cannot be converted to angiotensin 1. So here angiotensin 1 is not formed. Here angiotensin 2 is not formed. Here 1, 2 both are formed, but they cannot go to the receptor and bind with it. So this is how you have to explain in the form of the flowchart and diagram. Everyone give me a thumbs up. Pharmacokinetics, learn by yourself. Right, I'm not teaching you, but for the prototype drug, here prototype drug is captopril, here prototype drug is losartan, and here prototype drug is aliskiran. So learn the pharmacokinetics for that. Uses, I already taught you the mnemonic for the uses, I guess. Here home care makes patient definitely strong. So uses are same here, but we prefer ARBs among the 3. ARBs are the best. These are not very strong drugs, so we don't prefer them. We use as a second line. These 2 are first line. Usme se bhi preference is ARB followed by ACE inhibitor. So this is the summary. Adverse effect, you know it is captopril. Captopril is the mnemonic. From captopril, remove C, A, and I. The remaining are the adverse effect here. And here acidity and abdominal pain, yeah, adverse effect. Contraindication is PARC. It is same everywhere. Everyone give me a thumbs up. I'm done with the 3 chapters. I'm starting the second chapter right now. One more chapter we will do in this lecture only. Very fast. I will be super duper fast. Everyone give me a thumbs up. Shall I start? So Osama, Ashwin, Tejaswini, Shikhar, Ayush, Kumari, Rishita, Shakshi. Can I start? I can't see other names. Can I start? I'm starting my second chapter. My second chapter is anti-angina drugs. Okay. I will teach you all anti-angina drugs right now. Before that, you must understand what is angina. As I have taught you the drugs acting on RAS, but before that, I taught you what is RAS. If you understand RAS, you can understand the drugs inhibiting RAS. In the same way, if you understand angina, you will be able to understand the mechanism of action of anti-anginal drugs. So before starting that, I will teach you in the 2 minutes what is angina. Let me start with angina. Angina is chest pain. Patient have severe chest pain over the just below the sternum at the position of the heart. So patient has chest pain, or chest pain की जगह कहो chest discomfort. Actually, it is not pain, it is the heaviness in the chest. Heaviness in the chest, squeezing feeling in the chest, that is known as angina. And it is not permanent. It comes in attacks. Patient have chest pain whenever patient do the increased physical activity. If the patient is sitting on a chair, patient don't have anything. If the patient start running, jogging, or doing anything which increases the physical activity, patient have chest pain. Again, patient stop and sit down, then the chest pain will go away. So it comes in attacks like asthma. It comes, it go. It comes, it go. So it is paroxysmal. Paroxysmal means attacks. Angina is chest pain. Basically, it is chest pain. So now the thing why it has happened. Can you see a heart in front of you? Can you see the 4 chambers of the heart in front of you? Yes. Can you see the complete heart cycle? You already know the right side, the left side. You know everything. Now you concentrate on the left side. From the left side, can you see this is the left ventricle? Yes, you all can see this is the left ventricle. So this is the aorta. This is the aorta coming out of the left ventricle. Give me a thumbs up. This is the aorta coming out of the left ventricle. From the left ventricle, this is how aorta is coming out. Now, when the left ventricle contracts, blood comes in the aorta. We all know that. So heart is contracting. The left ventricle, the wall of the left ventricle having cells. Let me draw a few cells here. These are the cells in the wall of the left ventricle. They are doing systole. Whenever these cells are contracting, blood is coming in aorta and heart is giving. The aorta is distributing blood to all organs of human body. So all the organs are receiving blood from the aorta when left ventricle is contracting. But for contracting, who is giving blood to the heart? For contraction, heart also requires energy. Now, the cells in the left ventricle wall, they also requires energy. They also require blood. They also require ATP, and ATP will be formed from the oxygen of blood. So they require blood. So we will give blood to the heart via coronary. Can you see I have drawn a coronary in this diagram? Please appreciate there is a bigger coronary, this one. It is a branch of aorta only. This coronary is known as conductance vessel, the bigger one. And from the bigger one, small coronaries are coming out. These are known as resistance vessel. So from one big conductance coronary, small resistance coronaries are coming out. Everyone give me a thumbs up. So from one bigger conductance vessel, multiple small resistance vessel are coming out and they are supplying the blood to the wall of the heart. So we give the blood to the heart via coronary. So this is the supply. This is the supply to the heart. We are supplying the blood to the heart and we are demanding the blood from the heart from the aorta. So the left ventricle is contracting and giving the blood to human body. That is the demand. That is the demand of human body from heart. So we are supplying the blood. We are taking the demand. Give me a thumbs up. Everyone give me a thumbs up. If we give more blood via coronary, so the cells will receive more blood. They will form more oxygen. They will receive more oxygen. They will form more ATP. So they will contract more vigorously. If they contract more vigorously, more blood will come in aorta. So if we give more blood to the heart, heart will give more blood to us. If we increase the blood supply in the coronary, heart will give more blood in the aorta by contracting more vigorously. Give me a thumbs up. On the contrary, if we decrease the blood supply of the heart, right? If we are decreasing blood in the coronary due to the obstruction in coronary, atherosclerosis in coronary, vasospasm in coronary, so the cells will receive less blood. So they will contract less vigorously. They will contract sluggishly in the systole. So less blood will come in the aorta. So that is a direct relation. This is known as demand supply ratio. So you are giving more, you are asking for more. You are giving less, asking for less. Give me a thumbs up. So this is a rule of this universe. Whatever you give, that only come back to you. Not more, not less, right? This is a spiritual law also. जो दोगे वही पाओगे. उससे ना ज़्यादा पाओगे ना उससे कम पाओगे. So that's applicable for heart also. You got my point? It cannot happen. You are giving less and ask for more, right? It is selfishness. You cannot do that, right? So imagine a situation. Here the coronary got obstructed. If the coronary got obstructed due to atherosclerosis, due to thrombus, due to vasospasm, due to any reason, so you are giving less blood to the heart, but you are asking for more. So there is pain. So the cells in the wall of the heart, the cells, they will undergo ischemia, because you are giving less blood to them and asking for more. You are asking them to do more work, to contract more vigorously, but you will supply them less, right? So there is ischemia. There is ischemia in them. That ischemia causes chest pain. So this is angina. Basically, the definition of angina, imbalance between demand and supply. There is an imbalance. There is less supply and more demand. This imbalance leads to chest pain. That is angina. Give me a thumbs up if you got the definition of angina. Angina, everyone. Angina is nothing. It is the demand-supply imbalance. Imagine a situation. There is a servant at your home. There is an employee. You are giving less salary. You are asking for more work. What will happen? He will leave the job, or he will not do the job by happiness, right? So that is the thing. वो सब काम बिगाड़ेगा घर के, क्योंकि उसको पूरा टाइम रहेगा कि मिलता कम है और देना ज्यादा पड़ता है. So same thing is happening with the heart. There is imbalance. You are giving less, you are asking for more, right? That is imbalance. Now there are three types of angina. You have to understand the three types. This is the same diagram given in Robbins, not Robbins. This is the same diagram given in KDT. For explaining angina. This wall is the left ventricle wall. You can see the bigger coronaries conductance and small coronaries, that is resistance vessel, are coming out of it and supplying the wall. Now there are three type of angina: classical one, unstable one, and variant or Prinzmantle one. You have to understand the mechanism of each of them, so that whenever I will teach you the drugs on angina, for each drug you have to tell me that drug is useful in which angina. Which angina? The three anginas have three different treatments. Give me a thumbs up. So first understand the pathogenesis, right? So classical angina, in classical angina, what is the problem? See, this is the problem. Can you see the diagram? I guess everyone can see the diagram. See the diagram. In the coronary, what is the problem? There is atherosclerosis in the bigger coronary. The conductance vessel in the coronary is atherosclerosed. Atherosclerosis is partial. So it is partial obstruction in the coronary. So the wall of the heart getting blood, but less blood. The wall of the heart still getting blood, but less, because there is partial obstruction because of atherosclerosis. So that less blood is sufficient for rest. If I'm resting, not doing anything, I'm the patient, my coronary, the bigger coronary, my coronary is obstructed with atherosclerosis. So my left ventricle wall get blood, but that blood is sufficient for rest. But if I start doing jogging, running, anything which increases my physical activity, at that time my organs demand more blood. So I want the left ventricle to contract more vigorously at that time. So heart will say, no, I cannot contract more vigorously because you are giving me less blood, so I will contract sluggishly only. So at that time, patient have chest pain. So here the attacks are provoked by exercise, by anything which increases physical activity, and they are predictable. And attacks are subsided when the patient is resting. So that is classical angina. And here the problem is atherosclerosis in the coronary. That's it. Give me a thumbs up. The second angina is the variant or Prinzmantle angina. Thumbs up though. Here, what is the problem? See, this is the problem. In the coronary, if you zoom this portion and see, there is no atherosclerosis. There is vasospasm. The coronary undergoes spasm temporarily due to any reason. So coronary, a fragment of the coronary, the bigger coronary, conductance vessel, it undergoes spasm. So here you want to give vasodilators. If you give vasodilators, the spasm will go, and the coronary, basically coronary dilator, arteriodilator. Coronary is an artery, it is not a vein. So you want to give arteriodilator here as a part of treatment. Give me a thumbs up. Give me a thumbs up. And third is unstable angina. In unstable angina, the problem here in the coronary, there is platelet deposition. It is not atherosclerosis, it is thrombus. So thrombus is obstructing the coronary, so you give anti-thrombotic drugs, right? Anti-platelet drugs. Okay. We got the three type of angina. Now these are the drugs. For the treatment of angina, we have 5 type of drugs available in the market. The most important are nitrates, which I'm going to teach you in detail in this lecture. Nitrates. The second are beta blockers. The third is calcium channel blocker. So we have nitrates, we have beta blocker, we have calcium channel blocker, we have potassium channel opener. Beta blocker, calcium channel blocker, but potassium opener. Others may only one is important, daprodamol. That comes in your university exam for 2 mark or 3 mark. Why nowadays it is banned? It is contraindicated. The examiner asks you why it is banned. Tell the reason. I will explain you that also. But in previous era, it was used extensively for the treatment of angina, but nowadays it is not used. I will tell you everything. So these are the 5 categories. What are the 5 categories? The first category is nitrate. Second is beta blocker. The second is calcium channel blocker. The fourth is potassium channel opener, and others. In others, there is daprodamol. Everyone give me a thumbs up. Jitne audience hote thumbs up do. So for all 5 categories, the same headings, right? In detail, I will teach you only 2 here. For university exam point of view, I will teach you nitrates. I will teach you calcium channel blocker in detail, right? And in others, I will teach you daprodamol. ठीक है, बीटा ब्लॉकर you have already studied in ANS ना, तो यहाँ पे मुझे बीटा ब्लॉकर पढ़ाने की जरूरत नहीं है. You have already studied this in ANS, और I will teach you beta blockers in ANS. तो यहाँ पे these are not very important drugs. Here important one are nitrates and calcium channel blockers. Everyone give me a thumbs up. जितने audience उतनी thumbs up. So same headings will be there. So my headings are always fixed. I will start with the classification, move to the mechanism of action, then move to the pharmacokinetics, then move to the uses, then move to the adverse effects, then move to the contraindication, in the end interaction. For this also, this also, this also, this also, this also. These headings are fixed. If any question in pharmacology in your university exam coming for 5 marks, you have to describe that drug, that category into these headings. Then only you will get complete 5 marks. Complete 5 kabhi nahi milenge, you will get 4.5. If you are writing everything in this sequence only, everyone give me a thumbs up. Shall I start? Shall I start? Swaraj, Tejaswini, Kumari, Rishita, Nevirapine. Can I start? Right. Okay. So I'm starting with the first category, nitrates. These are anti-angina drugs. Let me start with nitrates. As usual, my headings. Let me start with classification of nitrates. How many nitrates are there? There are two types of nitrates based on their duration of action. Some are short acting, some are long acting. We are having two types of nitrates in the world. Some are short acting, some are long acting. Short acting are only two, that is GT and glyceryl trinitrate. Okay, GT and glyceryl trinitrate and isosorbide dinitrate, IDN. So glyceryl trinitrate and isosorbide dinitrate. These both are short acting. Coming on long acting में we are having four. So again isosorbide dinitrate तो यहाँ था. It is isosorbide dinitrate is both. It is short acting also, long acting also. Isosorbide dinitrate. If you give the patient isosorbide dinitrate by sublingual route, it is short acting. If you give the same isosorbide dinitrate by oral route, it will become long acting. Give me a thumbs up. अगर जबान के नीचे रखेगा तो फटाफट एक्ट करेगा, अगर पानी से लेगा और इंटेस्टाइन में जाएगा तो धीरे धीरे एक्ट करेगा. So short acting, long acting. In case of emergency, give sublingual. In case of maintenance, give oral. Give me a thumbs up. You got my point. So isosorbide dinitrate is at both. So it is a very important question. Isosorbide mononitrate is also there. It is only long acting, right? उसके अलावा we have erythritol tetranitrate and pentaerythritol tetranitrate. So erythritol और उसी का form pentaerythritol tetranitrate. So what is the classification? Some are short acting which are used in emergency at the time of the attack. Patient has severe chest pain, angina attack, give short acting, right? And some are long acting. Long acting are for maintenance. Short acting are given by sublingual route. They are given by sublingual route, जबान के नीचे रखने वाली गोली. And long acting are given by oral route. Give me a thumbs up. Everyone give me a thumbs up. Short acting are only 2 in number and long acting are 4 in number. Who will tell me? Here GTN, glyceryl trinitrate, isosorbide dinitrate. Isosorbide dinitrate, here also we have, the root is different, it is common, isosorbide mononitrate. Apart from it, we have erythritol tetranitrate and pentaerythritol tetranitrate. I cannot simplify more than this. These are the heights. Give me a thumbs up. So total we are having 6 nitrates, 2 plus 4. Give me a thumbs up if you got the classification. After classification, I shall move on mechanism of action. It is difficult. Mechanism of action. It is difficult. I'm coming on mechanism of action. Tell me the organ on which it acts. पहले तो organ बताओ. Mechanism तो बाद में समझेंगे. First tell me the organ. It acts on blood vessel, wall of the blood vessel. In the wall of the blood vessel, we have 3 layers, intima, media and externa. So it acts on media. In the wall of the blood vessel, it acts on the cells of the media. The cells of the media are smooth muscle cells. It acts on smooth muscle cells of media of blood vessel. First understand the organ. Uske baad I will teach you how it acts. How it is useful in angina. It acts on smooth muscle cells. Can you see a blood vessel in front of you? Everyone give me a thumbs up. Everyone give me a thumbs up. So, can you see a blood vessel? Can you see the 3 layers of the blood vessel? Intima, media and externa. Can you see the media? Can you see the yellow color cell in the media? These all yellow color cells in the media are smooth muscle cells. In the media, these are smooth muscle cells and this is the site of action of nitrate. Imagine I'm giving the nitrate to the patient by sublingual route or oral route. If I'm giving sublingual, the patient will keep the tablet here, just below the tongue. If I'm giving oral, patient will take the tablet with water and the nitrate will go in the stomach and intestine. Ultimately, from sublingual also it will be absorbed in blood. From intestine also it will be absorbed in blood. So ultimately, this is my nitrate. It is absorbed in the blood. It is absorbed in the blood. It is present in the lumen of the blood. Give me a thumbs up, everyone. So in the lumen of the blood. Now in the blood vessel, there is an enzyme which converts nitrate to NO. Which converts nitrate to NO. There is an enzyme. This enzyme is basically present in veins. It is not present in arteries. That's why nitrates are more active in veins as compared to arteries. This is the reason. So in the lumen of the blood, all the nitrates get converted to NO and this NO will enter inside these yellow cells, smooth muscle cells, and show its mechanism of action. Give me a thumbs up. After entering inside this NO, this is a cell. Can you see this yellow cell? This yellow cell is the cell of a media, smooth muscle cell of the media. You must understand this yellow cell is this cell. You must understand this. This yellow cell is this cell. Everyone give me a thumbs up. So nitrate get converted to NO and can you see these are the nitrates. In the lumen they get converted into NO and can you see this NO is entering from the lumen into the cell. After entering inside the cell it will show 2 mechanisms. After entering inside the cell what it will do? It will stimulate an enzyme guanylyl cyclase. This nitrate will stimulate, NO will stimulate an enzyme guanylyl cyclase. Guanylyl cyclase convert GTP to cyclic GMP. So basically nitrates increases the concentration of cyclic GMP in the blood. I will draw this diagram for you. In my diagram, you will have a better understanding, I guess. So let me draw this cell. What is this cell? This is the smooth muscle cell of the media of the blood vessel, right? So this is my tablet nitrate. Nitrate. In the blood vessel, nitrate get converted to NO. Basically in the veins, not in arteries, because the enzyme for converting nitrate to NO is present in veins. After formation NO, it will come inside the cell. This is a smooth muscle cell of the media. This NO is coming inside. After coming inside, this NO stimulates an enzyme. The name of the enzyme is guanylyl cyclase. It will become stimulated by NO. NO stimulates this enzyme. On activating, guanylyl cyclase convert ATP to cyclic GTP to cyclic GMP. GTP to cyclic GMP. So basically nitrate NO increases cyclic GMP in the cell. So basically it increases cyclic GMP in the blood. Everyone give me a thumbs up. Till now, is it clear to you? Can you see a cell? This is a cell of the media of the blood vessel. So nitrates first convert into NO in the lumen of the blood. There is an enzyme basically present in the veins which converts the nitrate into NO. After converting into NO, this NO will enter inside the media cell, the smooth muscle cell. After entering inside, it will stimulate an enzyme known as guanylyl cyclase. Guanylyl cyclase on activating converts GTP to cyclic GMP. So basically nitrates increase cyclic GMP. Now this cyclic GMP will do two things. What two things? What two things? You tell me one by one. What it will do? It will do two things. This cyclic GMP, number one, on the surface of the cell, there are calcium channels. There are calcium channels. It is blocking the calcium channel. So no calcium can enter, and without calcium, contraction cannot occur. So this cell cannot contract. This cell will relax because of the blocking of calcium channel. So cyclic GMP is inhibiting the calcium channels present on the surface. So calcium cannot come in. So intracellular concentration of calcium will fall. So cell cannot contract. For contraction, cell require three things: actin, myosin, and calcium. So it is calcium is absent, so cell cannot contract. So basically it is causing relaxation. This cell will relax because of this. Give me a thumbs up. The second mechanism, this cyclic GMP inhibits the phosphorylation of myosin. You know, there is actin, there is myosin. Myosin requires phosphorylation for doing contraction. So it inhibits the phosphorylation of myosin. So myosin is not phosphorylated. So if myosin is not phosphorylated, it will not combine with actin. It cannot combine with actin. So contraction coupling will not take place. So contraction will not take place. Again, this cell will relax. Because of both of this mechanism, the cell will ultimately relax. Everyone give me a thumbs up. You got the two mechanisms. This is the summary. There are two mechanisms. Both I taught you. What are the two mechanisms? First, make cyclic GMP. Nitrates increases the concentration of cyclic GMP by stimulating an enzyme guanylyl cyclase, and after that it does two things. It inhibits calcium channel. It inhibits phosphorylation of myosin. Because of both of which, ultimately it causes relaxation of the cell of the media. Relaxation of the cell of the media means vasodilatation. The blood vessel will dilate. Basically, veins are dilating, not arteries, because nitrates are more active in veins as compared to arteries. So nitrates are venodilators. This is my punchline. Nitrates are venodilators. You got my point? So they are vasodilators, but basically venodilators. See, smooth muscle cell ke andar, the nitrate will convert. It will denitrate it and convert into nitric oxide in the vein. Now this NO will enter inside and activate the enzyme guanylyl cyclase. Guanylyl cyclase converts GTP to cyclic GMP. Now this cyclic GMP will do two things. Number one, this cyclic GMP inhibit the phosphorylation of myosin. So it inhibits the phosphorylation of myosin, and that's why myosin cannot combine with actin. So contraction cannot take place. So relaxation take place, which leads to vasodilatation. Number two, this cyclic GMP inhibits calcium channel. So less calcium in the cell. So no contraction. So relaxation, so vasodilatation. Everyone give me a thumbs up. This is how you have to write in your exam. See both visible in this diagram. I will show you both mechanism in this diagram. See, this is nitrate. Nitrate get converted to NO. NO is entering inside the cell. This NO, after entering inside the cell, converts GTP into cyclic GMP by stimulating guanylyl cyclase. This cyclic GMP is making two inhibition. See, two inhibitions. Number one, minus. It is inhibiting calcium channel. And number two, minus is here. It is inhibiting myosin light chain kinase. That is myosin. Myosin light chain kinase ka phosphorylation. So there is no phosphorylation of myosin. If myosin is not phosphorylated, it cannot combine with actin. If it cannot combine with actin, there is no contraction. There is no contraction means relaxation. So basically this cell will relax. Ultimately, it will lead to vasodilatation of the blood. So if all the yellow cells, can you see here, yellow cells? All the yellow cells are relaxing. They all relax because of the double mechanism. By inhibiting calcium channel on their surface and by inhibiting phosphorylation of the myosin. Because of them, they are relaxing. So the blood vessel will vasodilate. This blood vessel is a vein. That's why venodilatation. So basically nitrates are venodilatation. Everyone give me a thumbs up. Everyone. So it is the 2-mark question. Why nitrates are venodilators, not arteriodilators? Why? Because the enzyme which is responsible for conversion of nitrate to NO, that enzyme present in veins. That's why. Give me a thumbs up. Now, these cells, the yellow cells are smooth muscle cells, which are present in the media of the blood vessel. Along with media of the blood vessel, this is the blood vessel. In the media, these smooth muscle cells are present. These smooth muscle cells are also present in bile duct. Bile duct. These smooth muscle cells are also present in esophagus. They are also present in esophagus. Smooth muscle cells, they are present in blood vessel, in the bile duct, in the esophagus. So whenever I am giving patient a tablet of nitrate, all the smooth muscle cells present in the entire body will relax. So blood vessel, they are relaxing, causing vasodilation. Bile duct will also relax and esophagus will also relax. So increased lumen of bile duct and esophagus. These are the other uses or side effects of the nitrates apart from the blood vessel. Currently in angina, I'm interested in blood vessel, but other uses are these also. Give me a thumbs up. Give me a thumbs up. This is written here. It is in bile duct and esophagus also. Everywhere it is relaxing. Give me a thumbs up. Now, okay, we got it. Nitrate is causing vasodilation. Listen now, the summary. Nitrate causes, everyone listen the summary. Nitrate causes vasodilation. Nitrate causes vasodilation. Okay. At low dose and at high dose. At low dose, it causes venodilatation. But at high dose, it causes veno as well as arteriodilatation. So basically, it is a venodilator, but at high dose, it is arteriodilator also. Venodilator, arteriodilator. This is the summary. Okay. And this is how it is happening. You got the mechanism of action by increasing cyclic GMP, and cyclic GMP is causing this. So we got everything. Now you tell me how the vasodilatation is useful in angina. I'm not interested in vasodilatation. I'm interested in angina. How vasodilatation is treating angina. And I taught you 3 anginas. Now, in which angina it is useful? Is it useful in classical? Is it useful in variant or transmantle? Or it is useful in unstable? You tell me. You got my point. So let me explain you how vasodilatation is useful in angina. Vasodilatation is useful in angina by 3 mechanisms. By decreasing preload, by decreasing afterload, and redistribution of the coronary, which is most difficult to understand. यहाँ पे जितनी audience है ना, 50% को भी ये समझ में नहीं आने वाला third mechanism. But I will try my best. Listen. You see, this is a heart. What is preload? What is heart? Nitrates basically dilates what? Artery की vein. Nitrates basically dilate what? Artery की vein. It dilates vein. Nitrates basically dilate vein. Vein means SVC, IVC. So nitrates dilate SVC and IVC. So imagine if I'm giving a tablet of nitrate to my patient who is having angina. My patient, this is a heart of a patient who is having angina. This patient is having angina. So there is imbalance in demand and supply. So what you are doing basically, you are giving the nitrate, the tablet of nitrate sublingual. Patient is having chest pain, you give nitrate sublingual. So that nitrates at low dose dilate the vein. Vein means SVC, IVC. All the SVC, IVC and all the veins in the organ, they got dilated. So all the blood in the body, 5 liters of the blood, maximum blood will be in the veins. It will not come in the blood because the capacity of the veins is increased now. So there is more space, more capacity inside the veins. So blood will remain here only. So less blood will come in the heart. So the preload decreases. You are decreasing the load on the heart. The heart is weak now. You are decreasing the load. Heart cannot perform the function. You are decreasing the workload of the heart. Number 1. This is how. At high dose, not only veins, it dilates artery also. Artery means aorta. So it dilates artery also. Imagine the aorta is dilated. At high dose, this aorta is dilated. Give me a thumbs up. This aorta is dilated at high dose. It is arterial dilator. So left ventricle, initially when aorta was not dilated, it was narrow. So left ventricle have to contract vigorously during systole to push the blood into the aorta. But now aorta is wide, it is dilated. So left ventricle have to push a little, very little resistance is there. That left ventricle have to do, that is afterload. So it decreases afterload also. So it decreases preload by dilating veins. It decreases afterload by dilating arteries. That's why useful in angina. These two are useful in classical angina. In classical angina, you are giving less blood to the heart now. So heart also want to do less work. Yes or no? You are giving less blood via coronary. You are reducing the blood via the coronary because there is atherosclerosis in the coronary. In the coronary, there is atherosclerosis. So you are reducing the blood supply of the heart by reducing the blood in the coronary. So heart will also want to do less work. Heart will say it's okay. You want to give me less blood, it's okay, but I will do less work for you. So please make the ways how I do less work. So I will ask the heart to do less work by reducing the preload. I'm giving less blood to the heart. All the blood will remain in the veins only. So heart के पास blood जाएगा नहीं, तो heart को काम नहीं करना पड़ेगा. That is how I'm reducing the workload of the heart, and I'm reducing the afterload by dilating veins, by dilating arteries. I'm dilating the aorta. So left ventricle have to push a little to push the blood into the aorta. Give me a thumbs up. So I'm reducing preload, afterload. Preload depends on veins and afterload depends on arteries. I guess everyone knows this. These are the basics. So I'm reducing the workload of the heart. I'm not increasing coronary supply. Coronary to kam hi hai, but to make the balance again. Currently, what is the problem? You are giving less blood in the coronary because the coronary is obstructed, but you are asking for more work. So there is an imbalance. This imbalance leads to chest pain. This is imbalance. Imbalance leads to chest pain. Imbalance leads to chest pain. That leads to angina. Now you want to balance again. There are two ways to balance. So either increase the coronary so that increased workload is matched with increased coronary, but we cannot increase the coronary blood flow because there is an obstruction, atherosclerosis. I cannot remove the obstruction. For that, I have to do a bypass surgery, right? So I do not want to surgery in my patient. Give me a thumbs up. I want to give some medical treatment. So coronary cannot be opened. The other way around, reduce the workload. For reducing the workload, the coronary blood supply is reduced, you are reducing the workload. So you are reducing preload also, you are reducing afterload also. By dilating veins, you are reducing preload. By dilating arteries, you are reducing afterload. So ultimately, you are reducing the workload of the heart, and this is how it is useful in classical angina. Everyone give me a thumbs up. I'm really trying hard. And really, students don't understand the basic concepts. That's why they have difficulty, right? This is how. So nitrates dilates vein. That's why they reduce preload. Nitrates at high dose dilates artery. That's why reduces afterload. In both of them, the workload of the heart is reduced because coronary supply is already reduced. So you are reducing the workload to make the balance again. You cannot increase coronary, so reduce the work. So balance should be there. If less coronary blood supply, less blood. Give me a thumbs up, everyone. So these two mechanisms are useful for classical angina. So see how to write in your exam. So write for the preload like this: nitrate dilate vein more than arteries at low doses. So if veins are dilated, most of the blood will be there in the veins only. There is peripheral pulling of the blood. So decrease venous return. So most of the blood will remain in the veins. So venous return is decreased. So less venous return, less preload, less cardiac work, and it is relief in angina. This is how. At high doses, nitrates produce arterial dilatation also. At high doses, it produces arterial dilatation. So the aorta is dilated. Here, aorta will be dilated. If aorta is dilated, afterload is reduced. So cardiac work is reduced. It is relief in angina. So by reducing preload and reducing afterload, by dilating veins, we are reducing preload. By dilating artery, we are reducing afterload. Ultimately, we are reducing the workload. Listen now, the third is most difficult. I can challenge, very few of you can understand it. It is difficult. Redistribution of the coronary blood flow. What do you mean by the word redistribution? Now, coronary is an artery or vein? I'm asking to you. You tell me. Yes, coronary is an artery. Everyone knows it now. So coronary is an artery. So at high dose, all arteries are dilated by nitrate. Coronary is an artery. It will also be dilated. You will say, ma'am, yes, coronary is an artery. And at high dose of nitrate, since all arteries are dilated, coronary is also an artery. It will also be dilated. Listen now. Which coronary? There are two coronaries. And it makes sense that which coronary is dilated. Conductance or resistance? I'm asking to you. I want to explain you something here. A big concept. Can you see this artery? The bigger coronary is known as conductance. This is conductance coronary, and the smaller one are known as resistance. These smaller one are known as resistance. For treating angina, you want to dilate which coronary? The bigger or smaller? You want to dilate or both? Which you want to dilate? I'm asking to you. First, you give your overview, then I will explain you what is the correct answer. So the bigger coronary is the conductance vessel, and the multiple small branches of the coronary is the resistance vessel. Multiple resistance vessel coming out of the big conductance. For treating angina, patient have angina. You want to dilate which coronary? Conductance or resistance? The bigger one or the smaller one? I'm asking to you. Swaraj, Tejaswini, Angha, Anagha, Nukul. Yes. So conductance. Nukul is saying conductance. Why Nukul? Why conductance? You should tell me the reason also. Why? Everyone is saying conductance, but why? Okay. Listen now. Listen, everyone, please be concentrated on your gadgets and please understand what I want to explain you. Listen, I have drawn these diagrams. I have taken the trouble to draw these diagrams before the lecture. so that with ease I can explain you, and in minimum time I can explain you the big concepts. Listen, see the first diagram. What is this diagram? This is the left. So I have zoomed out this version. Left ventricle wall and the coronary. Only this portion. I'm not drawing the complete chart. I'm drawing only left ventricular wall. So I'm drawing only left ventricular wall. Along with this is the conductance vessel, and these are the multiple small resistance vessel coming in the left wall. So this is the left wall. So see the first diagram. I've drawn 3 diagrams. See the first one. The first one is the normal. See everyone, what do you mean by normal? Normal means this is a big conductance vessel, and just suppose 5 small are coming. It can be any number. I have drawn 5 to explain you. The 5 small resistance are coming. Give me a thumbs up. And patient don't have angina. This is normal. Patient don't have angina. This is my heart, your heart, everyone's heart. Everyone give me a thumbs up. Till now, is it okay? Imagine 100 ml of blood is coming in this coronary. The bigger coronary, the conductance vessel. This is the bigger coronary, the conductance vessel. From conductance coronary, small resistance coronaries come out. When the patient is normal, not the patient, he's a healthy person. So like you, like me, like everyone, he is healthy. So the conductance में जितना blood आ रहा है, whatever blood coming in conductance, it is equally divided into the resistance. So whatever amount of coronaries, the resistance one are there, it is the conductance blood is equally divided in them. Just for example, if 100 ml is coming, it is divided 20, 20, 20, 20, 20 in 5. It is not there that there are 5 only. Just for explaining you, I have drawn this diagram. So I mean to say that whatever blood coming in conductance, it is equally divided into the parts in each resistance during normal, when the patient don't have angina. Now, patient have angina. What is there in the angina? In angina, one portion of the heart receive less blood and one portion of the heart receive more blood because there is some problem with the coronary. So the portion of the heart which receive less blood is known as ischemic zone. So imagine this is ischemic zone, and I mean this is non-ischemic zone. So one portion of the heart is ischemic, one is non-ischemic. Everyone give me a thumbs up. So body, God has given a beautiful compensatory mechanism in human body. God compensates everything without medicine. So there is a mechanism known as auto-regulation. This auto-regulation is compensatory mechanism done by the God, not by nitrate. I have not given the tablet to my patient. This is my healthy person. This healthy person have angina, attack of angina. At the time of the attack, his left ventricle is divided into 2 parts, ischemic zone and non-ischemic zone. Ischemic zone is the zone in which less blood supply, less oxygen is there. And non-ischemic is healthy. It is receiving normal blood and normal oxygen. So what God has done to compensate the resistance vessel, not conductance. The resistance in that area which is ischemic got dilated. But the resistance vessel in the area which is non-ischemic, it remains same. Now 100 ml of blood is coming. Again 100 ml is coming. You tell me what will happen now. Again 100 ml. But these 3 arteries, these 3 resistance are already dilated because they are in ischemic zone. It is done by auto-regulation by the God. So these will receive more. Initially all 5 were receiving 20, 20, 20, 20, 20. Now imagine these 3 are receiving 30, 30, 30. So out of 190 ml is given in the ischemic zone. Only 10, the 5 will be given in non-ischemic zone. Is it good or bad? You will say, ma'am, it is good. God is doing great thing. It is compensatory mechanism. It is auto-regulation. Without nitrate, it is done. So God is dilating the auto-regulation, the compensatory mechanism. It automatically it happens. You don't have to give any drug to the patient for this. So the resistance small coronaries are dilated automatically, not the bigger one. The smaller one are dilated automatically. It is auto-regulation compensation done by the God. Only in ischemic zone, not in non-ischemic zone. So this is also good. You want the more blood in ischemic, not in non-ischemic. That's why the resistance vessel in ischemic zone are dilated, but not in non-ischemic zone. Everyone give me a thumbs up. Is it now clear now? Now I am giving nitrate to my patient, a tablet of nitrate. Can you see? This is my patient and I am giving nitrate. Nitrates are also arteriodilator. They also dilate artery. Now, which artery they will dilate? They dilate conductance vessel. They don't have any role on resistance vessel. Because resistance to God संभाल ही रहा है ना. It is automatic. So nitrate is dilating the conductance vessel. Now see, instead of 100, if you give nitrate, so 200 ml of blood will go. तो सोने पे सुहागा. In Hindi there is a proverb. वो बात हो गई यहाँ. पहले ही God ने resistance vessel का dilatation कर दिया और nitrate ने ऊपर से conductance का भी कर दिया. So you got my point. So double useful advantage is there. Give me a thumbs up. So instead of 100, if 200 ml of blood is going, so initially 30, 30, 30, now 60, 60, 60. So this ischemic zone, instead of 90, it will receive 180 ml. and non-ischemic is receiving only 20. You got my point? So auto-regulation already happened. It already, you don't have to bother about it. You are a doctor, auto-regulation will be done, compensatory mechanism automatically in the body. You give nitrate to the patient, right? So the resistance vessel, the smaller one, are dilated by compensatory mechanism by the God. You are a doctor, you give nitrate. Your job is to dilate the conductance vessel, not the resistance vessel. Everyone give me a thumbs up. Everyone. This is known as favorable redistribution of blood. Favorable. Everyone give me a thumbs up. There is one more drug. Same diagram from KGT. There is one more drug in others. I told you daprodamol. It is banned nowadays. This drug is banned nowadays. So what? It is also an arteriodilator. It is also a coronary artery dilator. You will say, ma'am, then why it is banned? Because it is dilating the resistance vessel, not the conductance. So you will say, ma'am, what is the harm in that? Listen the story now for daprodamol. Listen the same diagram for daprodamol. Listen. This is normal. You already understood the normal. 100 ml of blood is coming, 20, 20, 20, 20, 20. It is divided equally in the 5 resistance vessel. Give me a thumbs up. Now the patient have attack of angina. At that attack of angina, this is ischemic zone and this is non-ischemic zone. So God does auto-regulation always. Whether you say or don't say, compensation always happen. So this 100 is now divided 30, 30, 30 in the ischemic zone. So ischemic zone is getting 90. Ischemic zone is getting 90. And non-ischemic zone is getting 10. So total 100 is there. But now you are giving a tablet of daprodamol. You are not giving nitrate. Nitrate is the conductance vessel dilator. But daprodamol is a resistance vessel dilator. Both are coronary dilator, nitrate and daprodamol. But nitrate is a bigger coronary dilator, conductance vessel dilator. And daprodamol is a smaller coronary dilator, that is resistance. What will happen now? So it will dilate the, जो God ने तो dilate करी रखी थी ना, the ischemic zone were already dilated. The daprodamol will dilate the resistance vessel in non-ischemic zone because the ischemic one were already dilated. Give me a thumbs up. The ischemic zone was already dilated. Now the non-ischemic was not dilated. So if you give daprodamol, the non-ischemic one is also dilated, which is not required. Why? Because you see now again all will become equal. All will become. So 100 ml if you are giving, so again 20, 20, 20. So it is 60 ml the ischemic. I'm interested in ischemic zone. So ischemic zone now. So without daprodamol, ischemic zone is getting 90. And with daprodamol, it is getting 60. So what happened? Oh my God, daprodamol decreased the blood supply of ischemic zone. So that's why it is banned. This is known as coronary steal phenomenon. It comes for 3-mark question. This is known as coronary steal. Steal यानी चुराना. In Hindi, the word steal. Steal यानी चोर, चुरा लिया. इसने coronary का blood उल्टा चुरा लिया. Coronary steal phenomenon. देने की जगह ये तो चोर निकला. इसने दिया नहीं, उल्टा ले लिया. You got my point. Do you understand Hindi? So the daprodamol is a stealer. Instead of increasing the blood on the coronary, it is decreasing the blood. So this is how it is decreasing. Everyone give me a thumbs up. This is known as coronary steal phenomenon, which is seen in daprodamol. That's why daprodamol is banned nowadays. Everyone give me a thumbs up. So I taught you. So this is for nitrates. Tell me what the nitrates are doing. Nitrates ka flowchart batao. Who will tell me? Nitrates relax the bigger conductance vessel, not the resistance vessel. This is the summary. So if the ischemia-induced autoregulatory dilatation of the resistance vessel is done by the cord in the ischemic zone, we know that, right? Not in the non-ischemic zone. In the ischemic zone, it is already done by autoregulation by compensatory mechanism. Nitrate blood. So nitrate dilates the conductance vessel. Now the increased blood is already diverted to the ischemic zone. That is how. So it is known as favorable redistribution. So there are two drugs. One is nitrate and one is daprodamol. Both are coronary dilators. This dilates conductance vessel and this dilates resistance vessel. This one is banned because it causes coronary steal phenomenon, and this is causing favorable redistribution. So I am done with mechanism of action of the nitrates. Do you have any doubt in that? In nitrate, I told you the classification. There are two types of nitrates, short acting and long acting. I taught you. So short acting are 2 and long acting are 4. So you know the 6 names, I guess. Mechanism of action, I taught you nitrate is a vasodilator. First, prove it is a vasodilator. How you will prove? So the nitrates. So first tell me the mechanism of action if coming. It will be a 3-mark question. Write the mechanism of action of nitrate. How you will write? You have to write first nitrate get converted to NO. This enzyme for conversion basically present in veins, not in arteries. That proves nitrates will cause dilatation of veins more preferably as compared to arteries. This NO will enter in the media, in the smooth muscle cell of the media. And after entering inside, it will stimulate an enzyme guanylyl cyclase so that more and more cyclic GMP is formed. The more and more cyclic GMP will do two things. It will inhibit two things basically. Number one, it inhibits calcium channel. Number two, it inhibits phosphorylation of myosin. Because of both of which the cell cannot contract. For contraction, calcium is required and myosin is required. Here, calcium is absent and phosphorylation of myosin is active. So contraction is not there, relaxation is there. Relaxation means vasodilatation. So this blood vessel will dilate, and basically veins are dilated more than arteries, right? So that is the thing. After now you have proven vasodilatation. Now make 3 arrows. I'm taking next page. You just continue here only. So vasodilatation happened already. How you proven that? Now vasodilatation of the veins, which is preferable at low dose, vasodilatation of the artery, which happens at high dose, and vasodilatation of the coronary, that happens at high dose. Now prove the 3 things. Vasodilatation of the veins reduces preload. That's why reduces the workload of the heart and useful in classical angina. Vasodilatation of the artery reduces afterload, so again reduces the workload of the heart, and that's why again useful in classical angina. Coronary, vasodilatation of the coronary. Which coronary? Conductance vessel, not resistance vessel. It causes favorable redistribution. By the word favorable, matlab sone pe sohaga. You know, so the resistance ones are already dilated in the ischemic zone by the God, that is compensatory mechanism, and here nitrate is dilating the conductance vessel. And this is useful in Prinzmantle angina. So these two are useful in classical angina, and this one is useful in Prinzmantle or variant angina. This is how you have to write in your exam. I am done with the mechanism of action. After that, pharmacokinetics, you learn the pharmacokinetics by yourself. What is the pharmacokinetics here? Nitrates have high first pass metabolism. If you have attended my yesterday's lecture of general pharmacology, you may be knowing what is first pass metabolism. All the drugs which have high first pass metabolism, don't give them by oral route. Yesterday I taught you. The first name was nitrate. If you have attended, have you attended my yesterday's lecture? I've given you a mnemonic. Nitrates have large PSM. If you attended, you may be knowing it. Nitrates are the drugs which are not given oral. So that's why they are given by sublingual route. Shortest acting is this one, longest acting is this one. Learn the shortest and longest acting. That's it. So that is pharmacokinetics, right? We are done with classification, mechanism of action, pharmacokinetics. Now uses, adverse effect, I am having 2 mnemonics. So uses ka mnemonic is A, B, C, D, E, F. A, B, C, D, E, F. A for angina. Of course, nitrates are useful in angina. 2 angina. Classical angina and Prinzmantle angina. Nitrates are not useful in unstable angina. Unstable angina mein thrombus is there. So you have to give antithrombotic drugs, antiplatelet drugs, not nitrates. But in classical angina, it decreases preload and afterload. And in Prinzmantle angina, it causes favorable redistribution of blood flow in the coronary. That's why it is useful in these 2 angina. You can explain them. I've already explained you. The B for biliary colic. I told you nitrates not only dilates arteries and veins, it dilates blood vessels, bile duct also. Because the smooth muscle cells are present in bile also. Not only this, the smooth muscle cells are present in esophagus also. So whenever there is esophagus spasm in a person, the esophagus got spasm, you give nitrate. So esophagus will also dilate. 3 things dilate: the blood vessels in angina, arteries and veins, the bile duct in biliary colic, and esophagus spasm, esophagus will dilate. Give me a thumbs up. C for cyanide poisoning. I have to explain you how nitrates are useful in cyanide poisoning. I will explain you. D for dil ka dohra. If you understand, dil ka dohra Hindi, dil ka dohra is MI. It is useful in MI. And F for failure, the heart failure, congestive heart failure. Everyone give me a thumbs up. It is A, B, C, D, E, F. In the full form: angina, biliary colic, cyanide poisoning, dil ka dohra, that is MI. E for esophagus spasm, and F, it is F. I'm sorry, this one is F. F is failure. Failure, the heart failure. Everyone give me a thumbs up. Everyone. So you can write your own in each of them. Except you don't know cyanide poisoning. I will explain you cyanide poisoning. Can you explain the others? How nitrates is useful in angina? You can make 3-4 pages. You can write down on that. How it is useful in classical. How it is useful in Prinzmantle. You write the mechanism of action here. How it is useful in biliary colic, you can explain them. How it is useful in esophagus spasm, you can explain. In congestive heart failure, again, it reduces preload and afterload. This is how it is useful in the weak heart, congestive heart. Now I'm explaining you only one cyanide poisoning. Rest, you don't enumerate in your exam, you write also. So enumeration, if you are a second prof student and attending my lecture for the university exam, after enumerating, please write 4 lines on each of them and explain how it is useful for this mechanism, for this, basically for this use. So you have to explain it also. I'm not explaining you, but you do it by your own, right? I'm explaining you only one cyanide poisoning. Cyanide is a poison, right? If someone have ingested poison, cyanide, the relatives are carrying this person to you, doctor saved this person, he has ingested cyanide by mistake. So the blood of this person contains cyanide. So cyanide is present in the blood and you want to save this person by mistake, by accident, by suicidal purpose, by homicide, he has ingested cyanide. So cyanide is present in the blood. Now I want to excrete the cyanide in urine. It is already present in the blood. How I will so that I can save the person. For saving the person, you want the cyanide to get excreted. Cyanide cannot directly excreted in the urine, right? Now I have to do something. So I will give nitrate to this person. I will give nitrate. What nitrate will do? Nitrate convert, this patient have hemoglobin. Everyone have hemoglobin in RBC, no? So nitrate convert hemoglobin into methemoglobin. That is the job of nitrate. So cyanide cannot combine with hemoglobin, but cyanide can combine with methemoglobin. That's why we are converting hemoglobin to methemoglobin so that cyanide can combine with methemoglobin. You got my point? So basically you are converting hemoglobin to methemoglobin by providing nitrate. That is the job of nitrate, math chapter nitrate here. Nitrate basically converts hemoglobin to methemoglobin so that cyanide can combine with methemoglobin and form cyanomethemoglobin. Cyanide cannot combine with hemoglobin. You got my point? Now cyanomethemoglobin is formed. This can be excreted in urine. This can be excreted in urine. See this. I'm converting hemoglobin to methemoglobin by giving nitrate. Now this methemoglobin combined with cyanide and forms cyanomethemoglobin. And now this will be excreted in urine by giving thiosulfate. If you give thiosulfate, methemoglobin will separate and sodium thiosulfate will be excreted in urine. This is how in cyanide poisoning I'm taking cyanide out of the body. So nitrate is useful here. Give me a thumbs up. Everyone give me a thumbs up. So I have done the uses. We are done with the uses. You want me to tell you the adverse effects also? What are the adverse effects? The adverse effects, I'm having a mnemonic for that also. The adverse effects are mnemonic TDS ROM, ROM. TDS. You know in income tax we have TDS now. TDS ROM. Learn like that or you can make some other mnemonic. Okay, I will explain you all. Let me explain you the side effects, then I will explain you the mnemonic. Right? Nitrates causes vasodilatation. Yes or no? Yes or no? So it causes artery dilatation as well as it causes vein dilatation. Artery as well as vein, preferably vein. Right? You know why humans have headache? Why we have headache? Especially migraine headache. So this is the brain. In the brain, when the blood vessels got dilated, now patients have headache. The patients have headache, right? So nitrates causes headache, the throbbing headache, especially migraine headache, because it causes vasodilatation of all the blood vessels. It causes vasodilatation of the brain blood vessels also. So that is headache. Headache is a side effect of nitrate. Give me a thumbs up. It is a side effect of nitrate. And not only brain blood vessel, it causes dilatation of the face, skin blood vessels, cutaneous blood vessels also. So patient look red in color. That is flushing. So flushing and headache are due to vasodilatation caused by the nitrates in the cutaneous blood vessel and in the brain blood vessel. Give me a thumbs up. So these are the two headaches, flushing and headache. After that, patient have vasodilatation. So the arteries dilate. For vasodilatation, what will happen to blood pressure? If vasodilatation is there, what will happen to BP? BP will fall. So basically nitrates causes hypotension. And because of that, there is reflex tachycardia, increased heart rate. Not direct action on the heart. Nitrates don't go to heart. Nitrates dilate blood vessel. They cause fall in BP, because of which reflex tachycardia is there. Second is reflex tachycardia, patient feel palpitation. It is not due to nitrate have something to do with the heart. No, nitrate causes it reflexy. Give me a thumbs up. Nitrate causes hypotension. It causes fall in BP. It causes rise in heart rate. So BP falls and heart rate increases reflexly heart rate increases. You got my point? And vasodilatation is there, which causes headache and cutaneous blood vessel dilatation that leads to flushing. Methemoglobinemia. In cyanide poisoning, this is useful, but other way it is not useful. So whenever you are giving any nitrate to the patient, hemoglobin get converted to methemoglobin. It is a side effect, right? Skin rashes is caused only by one pentaerythritol tetranitrate. They cause skin rashes. One is tolerance. What do you mean by tolerance? Now, it is very important to understand tolerance. I want to explain you a disease known as Monday disease. What do you mean by Monday disease? It is difficult, huh? What is tolerance? Tolerance का मतलब क्या होता है? You tell me हिंदी में मतलब क्या होता है? What do you mean by the word tolerance? Tolerance. Does anyone know the meaning of the tolerance? Nukul, Ashwin, Swaraj, Parag, anyone? Tolerance means if you start taking a drug, a new drug for any disease. So drug is active initially. Initially, it will show its action also, and mechanism of action also, and side effect also. Initially it is active, so show action and side effect. Those so drug have effect as well as side effect, but after few days or few time, the drug attenuate, so it neither shows its action nor shows side effect. So both will decrease, the action as well as side effect and side effect. After some time, if you prolong take the drug, कंटिन्यूअसली टेक द ड्रग, ड्रग अपना काम करना धीरे धीरे बंद कर देगी। पहली टैबलेट तो बढ़िया काम करेगी, दूसरी करेगी, तीसरी करेगी, चौथी थोड़ी कम करेगी, पांचवी और कम करेगी, छठी कम, सातवीं करेगी नहीं। सो दिस इज टॉलरेंस। सो टॉलरेंस में you have maximum action and side effect at the first day, and gradually action and side effect both reduces gradually they become zero. So at one point drug is not active in human body, that drug. So this mechanism is known as tolerance. I guess everyone knows it. So there are some drugs which have tolerance, right? There are some drugs which have tolerance, right? So nitrate is one of them. So that means if the patient taking nitrate continuously, if the patient taking nitrate continuously, it will be active on the first day. So it show effect also, side effect also, and gradually the effect and side effect both will fall. After some days there is zero, no effect and no side effect. Give me a thumbs up. This is tolerance. If I take the nitrate continuously, right? That's why nitrates are never given continuously. They are given only at the time of the attack. When attacks are predictable and attacks are already arrived, only at that time we give nitrates, otherwise we don't give nitrates, right? This is the reason why nitrates are not given continuously. And at least in human body, 8-hour drug-free interval should be there in the blood. 8-hour drug-free interval agar hai, the tolerance will not develop. This will develop if drug is present continuously in the blood. But if you are giving the drug, then not giving the drug, then giving the drug. So every time drug will show full action. It will not show tolerance. There should be break in between. You got my point? You got, so that is tolerance. So 8-hour drug-free interval should be there. That is attenuation of the anti-ischemic effect of the nitrate occurs if nitrate is present continuously in the blood. So don't give nitrate continuously. Give only at the time of the attack. And give at least 8-hour drug-free interval. Don't give continuously. Give me a thumbs up. Now there is a disease known as Monday disease based on that. It comes for 2 marks question. How nitrate causes Monday disease? What is Monday disease? Now there are some factories inside which nitrate is used as a raw material for the preparation of some products, right? Nitrates are commonly used in the factories. Now there are many workers in the factories. So he's a worker, he newly joined the factory. See, he's a worker, he newly joined the factory, right? In which nitrate is used as a product for forming, as a raw material for forming some product. So he got the new job. He's very happy, very excited. On Monday, he joined the job, right? On Monday, he joined the job. So he is exposed to nitrate. He is exposed to nitrate in the factory, right? He is exposed to the nitrate. So nitrate causes vasodilation in the person, right? It causes vasodilation, we know. So this person have vasodilation in the brain also. So this person will feel headache on Monday. On Monday, he will have headache. So again, he is continuously working for 8 to 10 hours in the factory till night, right? So nitrate is continuously present in him. And before it vanishes in the night, again, next morning, he is coming to the factory. So nitrate, he is continuously on Tuesday also, on Wednesday also. So he is having on headache on Monday, Tuesday, Wednesday, he is having decreased headache. Thursday, he is having decreased headache. On Friday, he is never having no headache. No headache. Why? Because tolerance happens. Tolerance not only of effect, of side effect also happens. Tolerance, right? So gradually tolerance developed because nitrate was continuously present in his body. So gradually till Wednesday, Thursday, Friday, he was not having headache. He was having maximum headache on Monday, right? Tuesday, Wednesday, gradually it fall. And on Wednesday, Thursday onwards, he is having no headache. He was happy ki chalo headache theek ho gaya, badhiya. Now Saturday, Sunday is a holiday. Sunday is a holiday in every factory, no? So Sunday is a holiday. And after Sunday, on Monday, he again going to the job. On Monday, the next Monday, right? So there is an 8-hour drug-free interval, right? So attenuation, the tolerance vanishes, right? And again on Monday, he is having the same story. He is having headache again. So every Monday, he have headache. So he feels like every Monday, I'm having headache. He hate Monday. This is known as Monday disease. Everyone give me a thumbs up if you got Monday disease. By the way, everyone hate Mondays now. Even I also hate Monday. I love Saturday. So today is Saturday and everyone hate Monday. So this person also hate Monday, right? So that is known as Monday disease. So a special aspect of tolerance is in Monday disease. So the workers which work in the factories which involve nitrate, they feel headache every Monday. Within a day or two, the symptom disappear because the tolerance develops. So till Tuesday, Wednesday, the symptom disappear, headache disappear. So weekend terminates the exposure. More than 8-hour drug-free interval is there. And the symptoms reappear when the patient return to work on each Monday after Sunday. Everyone give me a thumbs up. This is Monday disease. And there is dependence also, nitrates. So what are the adverse effects? Now make the mnemonic. TDSROM. T for tolerance. You know what is tolerance? Tolerance mein Monday disease bhi mention karna, don't forget it. And T for throbbing headache. Patient has throbbing headache because of vasodilation of the brain blood vessels, right? D for dependency. S for skin rashes caused by penta-erythritol. R for reflex tachycardia. It is reflex due to hypotension. O for orthostatic hypotension, and M is methemoglobinemia. I guess everyone can explain it. Everyone give me a thumbs up. Everyone means everyone. This audience would be thumbs up. Last thing is the interaction of nitrate. Only one interaction is there. Never give nitrate with sildenafil. What is sildenafil? Sildenafil is a tablet. It is available in the market with the name Viagra. It is used for erection during sexual intercourse in males. So males for causing erection during sexual intercourse. So they take this tablet, that is sildenafil, or the person who is having erectile dysfunction. What is erection? In sexual intercourse, there are two things: erection and ejection, right? This is the penis of a male. This is the penis. This male is having a problem, erectile dysfunction. So during sexual intercourse, he can't erect the sexual organ, that is the penis. So why erection occurs? So inside the penis, these are the blood vessels. These are the blood vessels present inside the penis. When these blood vessels vasodilate, penis erect. So this is physiology. You may be knowing it. So penis erect when the blood vessels inside the penis undergo vasodilatation. Now in this person, this vasodilatation is not taking place. That's why this person is unable to erect the sexual organ during sexual intercourse, right? So this person is having a disease known as erectile dysfunction, right? Now the doctor want to, the urologist want to correct it, right? This person want the erection during sexual intercourse. So we give, being a doctor, we give a tablet known as sildenafil to this person. What does sildenafil do? Sildenafil causes vasodilatation. Sildenafil causes vasodilatation. Sildenafil also increases cyclic GMP. You know, cyclic GMP always causes vasodilatation. Sildenafil also increases cyclic GMP and it causes vasodilatation. So patient takes sildenafil tablet before sexual intercourse. So at the time of sexual intercourse, patients have erection of the penis and the disease is cured. That is, erectile dysfunction is cured, right? But if the patient is having angina also and patient is taking nitrate also along with the sildenafil, both will do same thing. Both will increase cyclic GMP. Both will cause vasodilatation. So vasodilatation इतना ज़्यादा हो जाएगा कि patient will go in hypotension or patient can go in shock and patient can die. It can be dangerous. So avoid the combination because both are doing the same thing. Both are increasing cyclic GMP. But the mechanism is different. How cyclic GMP is formed? Now see the summary. GMP, GTP get converted to cyclic GMP. Cyclic GMP. And cyclic GMP is degraded into GMP. Right? This is the complete story. So we want more and more cyclic GMP for causing vasodilatation. Give me a thumbs up. There are two enzymes. One enzyme is used in the formation, that is guanylyl cyclase, and one enzyme is used in the degradation, that is phosphodiesterase. So guanylyl cyclase causes formation of cyclic GMP. It increases cyclic GMP. And phosphodiesterase causes degradation of cyclic GMP. It decreases cyclic GMP. So there are two drugs. The first drug is nitrate. Nitrate stimulates guanylyl cyclase. With this mechanism, it increases the synthesis of cyclic GMP. The another drug, sildenafil inhibits phosphodiesterase. So it inhibits phosphodiesterase. So there is no enzyme now to degrade the cyclic GMP. So it increases cyclic GMP by reducing the degradation. Ultimately, both the drugs, nitrates and sildenafil, causes increase in cyclic GMP. So they cause vasodilatation. Never give them together. Everyone give me a thumbs up. That is the only interaction I want to explain you here. Everyone give me a thumbs up. Sildenafil. So sildenafil also increases cyclic GMP. It inhibits phosphodiesterase, right? So it increases cyclic GMP. Potential severe hypotension can occur if the two drugs are given together. This is sildenafil and NO together. Never give them. Never give them. So this is NO and this is sildenafil. If you give them together, cyclic GMP will increase drastically, right? Sildenafil is Viagra, right? So never give. Imagine a male, a 40-year male coming to your clinic and saying, doctor, I'm having ED, I'm having erectile dysfunction. And you give the person sildenafil. Okay, take sildenafil tablet before sexual intercourse. The ED should be treated, right? But the person forgot to tell you that I'm having angina also. And during sexual intercourse, he has chest pain also. So for that, he had consulted a cardiologist. And cardiologist has given the tablet nitrate to him. So cardiologist asked the patient before sexual intercourse, you should take nitrate, sublingual nitrate. It attacks predictable now. At the time of sexual intercourse, because of increased activity, heart activity increases, so patient have chest pain at the time of sexual intercourse. So before that, prophylactically, patient should take nitrate. And for ED, patient should take sildenafil. But the two things should not be combined together. These two things. The patient can go in hypotension. So that is the thing. You got my point. So give me a thumbs up if you got it. So we are done with nitrates. You know the classification, you know the mechanism of action, you know the pharmacokinetics, you know the users. What are the users? Who will tell me the users? What are the users? A, B, C, D, E, F. What are the adverse effects? T, D, S, Rho. What is the interaction? Sildenafil. Give me a thumbs up if you enjoyed the lecture. Everyone give me a thumbs up. Everyone. Users adverse effect. The first chapter nitrates are over. You want me to teach calcium channel blockers? Or shall I start the next chapter? The next chapter is heart failure drugs. Or you want me to complete calcium channel blockers also? So anyways, whatever you want, write down in the chat box. I'm having an eye on your chat. Here I would like to stop and take a break for 10 minutes, right? After that, I will continue my lecture on YouTube only. So thank you very much for being with me on this lecture. If you like the lecture and learn from the lecture, the first thing, write down in the comment box. Don't forget to give a comment, drop a comment in the comment box as a feedback, whatever is your feedback. Don't forget to click on the like button before leaving the lecture. Please drop a comment, and I would like to see you in the next class. The next class is just after 10 minutes. Just after 10 minutes at 10:20, I will start. Right now, just after 10 minutes, it's 10:10 now. I would like to have a cup of coffee, and after that, I will continue my episode number 2. So join episode number 2 on YouTube only, where you are attending right now at the same YouTube channel, that is Unacademy Live. There will be second lecture episode 2 just after 10 minutes. So we will continue on YouTube from 10 to 12. The next 2 hours, we will first finish this calcium channel blockers. After that, we will come on the next chapter, heart failure drugs, antihypertensive drugs, and after that, we will continue with CNS pharmacology. So don't forget to join me after 10 minutes. Thank you very much. I would like to see you all. And please, on Unacademy, everyone follow my profile link. What you do, you go on Unacademy Learners app. You may be knowing Unacademy Learners app. You have installed it from the Play Store. After that, select the category as NEET PG. NEET PG is a goal. It is a category for all medicos. After that, search my name. See the spelling of my name. It is Dr. Priyanka Sachdev. Under Plus Educators, you search my name. Along with my name, you will find a profile link. Click on the profile link and follow it. There are 2 advantages if you follow my profile link. Number 1, you will get a list of more than 1,000 recordings which are available free there. So all the recordings are available. You can watch any recording of your choice. It is patho, pharma, micro, medicine, PSM, multiple subjects. My lectures are available. You can watch it for free. All the recordings. Not only this, you can now download the PDF of the notes. So for all recordings, it is available on the app. But the only thing, you require a code. All the recordings are free. The notes are free, but you require a code to unlock it. Code is my surname, Sachdev, SACHDEV, Sachdev 10, without space 10. Sachdev 10 is the code. Note down this code. Distribute this code to all the medicos throughout the globe so that everyone can get benefit of the free education available on Unacademy. So please do it right now. If you have not done, follow my profile link. And the second thing, if you follow my profile link, you will get all the notifications 10 minutes before the class. You will never miss my class. So the code is Sachdev10. Note it down. Thank you very much. Yeah, I have already announced the Unacademy Learning Festival is going on. In Unacademy Learning Festival, at just rupees 299. You will get 1 month plus subscription of Unacademy. Don't miss out this opportunity. The offer is till 16th of May only. Today is 14th. Next 2 days, this offer is valid. So you will get the subscription, which is 2,000 in just 299. So you can see you are getting it less than 1/10 of the price. Come on. So you should take advantage of this opportunity, and you will have an experience of the plus classes. You can access all live and recorded lectures with the top educators, question bank, live quiz, all India mock test, grand test, batch courses. You can do everything on the platform. For this, again, you require a code. The code is my surname, Sachdev10. Use this code to avail this opportunity. Apply this code before payment. Before payment, apply my code and get the plus subscription at rupees 299. Thank you very much. Join me after 10 minutes on the same platform, episode number 2 of Systemic Pathology. Bye-bye.